Good morning,
Good
sir.
morning.
Morning.
Good morning, sir.
Good morning, everyone.
Good morning. Yeah, I see Raugar also with the new eyes.
Yes, sir. Namaste, sir. So, shall we start?
We can start now.
Sir?
Yeah.
Why your face are reddish, Karkabusham and Rao?
I don't know, sir. This why it is coming like this.
Problem with the PC.
Maybe PC problem.
Problem with the computer, sir.
Computer.
It's all right. Okay, now let us start. Without much ado, let us start. Now.
Okay.
Yes, sir. So first, I will say that you will give the message. Later, I will introduce the speaker, sir.
You want me to start now?
Please.
I will just invite, sir. Then.
Okay.
So, good morning, everybody. Today, on this World Autism Awareness Day, our Genome Foundation is trying to help the children and parents of autism spectrum disorder by arranging this first maiden attempt a webinar, which is very interactive to help the society. Our chairman and managing director, Dr. Gandhi Pichikaja, will deliver his message on this maiden initiative. Sir, I request our chairman, sir, to deliver his message.
Good morning and welcome all to this first seminar on role of genetics in autism. I only know how to think of doing good to the people. I do not know genetics. And I do not know autism also. I only know patients and parents and families suffering with autism patients in their home. And I also seen some patients with suffering from autism and the plight of the parents who are multimillionaires and probably billionaires also. And they are not able to do anything except feeling pity for the children and trying to explain to people like me who visit them, God has given everything, but this also He has given. We are taking it as a gift of the God only. And we are trying to do whatever best possible. We have shown Him to more than 100 doctors across, including US, India, and Britain and some other countries also, where they say that a lot of research is going on. But none of it has given a relief to my son, who is now 18-year-old. He is otherwise looking very beautiful, and he's also doing most of the things normally only. But there is some streak of some kind of innocence or some kind of aggravation, some kind of fear, some kind of boldness. All these multiple parameters I have seen in a short 2-3 minutes of time, and then this made me feel that this is something which needs to be done. If there is any possibility in Genome Foundation, which I have accidentally taken responsibility. Although I have been the co-founder with Dr. Lalji Singh, the understanding was that Lalji Singh will do everything in genetic related aspects. I will only support him in the managerial and executive aspects of it. As executive director and managing director, we worked for almost 15 years with other responsibilities. This we could not do much. Now, after I took charge about 5 years ago, I tried to do whatever is best, and I thank all the supporters who came voluntarily to share my responsibility, to share my award objectives, including Professor Rao, who is there, Dr. Kanakabhushan, who is there, and Dr. Sanja, who has been there along with our another director of research, Dr. Vishnupriya, and newly joined Dr. Nandini. So who has been supportive of this idea, and without her, showing um, complete commitment to the cause of this autism patient who she is dealing with. I couldn't have taken this bold venture of starting a webinar series, that too on a monthly basis. Our own clinician and scientist, both Rao and Kanakaposam, are less knowledgeable about the intrinsic issues related to autism, but for the fact that the scientist Sancha and the clinician Nandini, who are our eyes, and recently joined is RN, who is again a godsend suddenly to be uh, part of this entire initiative. With all the five of them, I am able to see on the screen, and none others I am able to see. Gargi is there silently doing the background work, and I have nothing else to say except that I am wishing the seminar all the well, and I have only one thing I can do. I can give logistic support, monetary support, whatever is possible, and also all other divine given blessings through the divinity. With these few remarks, I want all the five of you who are there on the whom I am able to see, who are the backbone of this autism seminar. I wish that the seminar will do uh, some good in the larger issues that are being faced by the patients across the country, and especially we want to start it in the Telugu states of two Telugu states, Andhra Pradesh and Telangana, and both Dr. Nandini and Dr. Aryan, who are there in the hospitals run by them and work where they are working also. They are going to become the important key functionaries for us to identify the patients, collect the samples, and then forward it to Sanjay and to Genome Foundation and any other lab which are going to do that. This is what I wanted to say. And once again, thank you for being with us. And together, let us make a difference to society. Thank you. I wish the initiative all the best with my whole heart. Thank you.
Thank you very much, sir. Thank you very much for your blessings. And we pray for the divine blessings also to help our efforts. Now, the three speakers will be delivering their remark, and after that, the parents and other participants, they can interact and they can raise their queries and they can get the clarifications from whatever problems and they are facing. Now, Dr. Nandini Bandikatla will be delivering her lecture. She will explain. She is very much experienced and very highly knowledgeable in this particular disorder and this problem of the children. She is Dr. Nandini Bandikatla is an UK-based child and adolescent psychiatrist currently practicing in India. She completed her MBBS from Kasturba Medical College, Manipal Academy of Higher Education, India. She completed her MRCP Psychiatry from Royal College of Psychiatry, London, UK. She has completed pursuing her MBA in Hospital Management from Alagappa University, India. She has an overall 15 years of experience in the field of child and adolescent psychiatry, working across various hospitals in UK and India. She is currently appointed as an executive board member for NEPID, that is National Institute of Health. She is currently working as a consultant child psychiatrist for Rainbow Hospitals, Vikrampuri and LB Nagar, Apollo Hospital, Jubilee Hills, and Indo-British Advanced Pain Clinic, Banjara Hills. She is currently serving as the founder for New Leaf Autism and ADHD Clinic, Banjara Hills. She received her certificate training as a professional in ADOS, that is Autism Diagnostic Observation Schedule at Oxford, UK. She also has an expertise in standardized assessment of ISA, that is Indian Scale of Autism Assessment, and CARS, that is Childhood Autism Rating Scale. The specialized areas of work revolves around ASD, Autism Spectrum Disorder, ADHD, Attention Deficit Hyperactive Disorder, ID, that is Intellectual Disability, SLD, Specific Learning Disabilities, various personality and mood disorders, psychosis, common adolescence problems like addiction, eating disorders, and adjustment disorders. With her wide experience and knowledge in this related field, we are expecting good results and a great help for the society. And I request Dr. Nandini to give her talk. And later, after completing the three talks, the participant can raise their queries and get the clarification from all these three speakers. Thank you. Dr. Nandini, please.
Thank you, Dr. Thank you, Dr. Kankumbhushan. That's a kind introduction. And good morning, everyone. I'm going to present, some other on autism spectrum disorder. And yeah, I'll try my best to make sure that you understand some part of this webinar at least, and then take some few points to take home so that you can take that message and then you can. So yeah, today I'm talking about this autism spectrum. Mostly I'm concentrating on the parental difficulties, what they see on a day-to-day basis. Before that, so what I'm going to briefly talk in my lecture today is what is actually the autism spectrum disorder and what are the causes of, and when to seek help, like what are the red flag signs that the mother or the father has to look into the child and then seek a specialist help. And if at all, if there is any treatment or any therapies, what is that they have to do. And the most important is what is the role of the parents when they get the diagnosis of ASD for the children. So this is what I'm going to talk about in my presentation, the next few slides. So what is autism?
Nandini ma'am, your presentation is not visible, ma'am. It's not visible yet. Press the share button, ma'am. Share.
1 second.
And then yeah.
We can change it. Screen sharing, madam.
Yeah, 1 second, Sharan.
Okay.
Okay. Is it visible now? Hello?
No, ma'am, not yet visible. Not yet visible, ma'am.
Oh.
Yes, ma'am. Now your screen is becoming visible. Yeah. Go to the slideshow mode, ma'am. Yeah.
Maybe it has gone into the sleep mode, I suppose. Okay. Anyway, sorry
Yes,
for
ma'am,
that.
now it's visible.
Yeah. Okay. So today in my, am I audible as well?
Yes, ma'am, you're audible, visible, and your slide is also seen.
Yes, yes. Okay. So in my lecture today, I'm going to concentrate on what exactly is autism spectrum disorder and what exactly the cause of it, when to seek help, and also what are the treatments for autism and what is the role as a parent. So what is autism? It is a developmental disability that impacts the normal development of brain in the areas of social interaction and communication skills. So it is mainly a neurodevelopmental disorder. What it means to say is when the baby is forming in the mother's womb, there is some abnormal development in the brain of the child, and that leads to autism. But the presentation of autism will happen only after the few months of the baby is born, not immediately. And why are we calling it as a spectrum? Because so far, like, it was very difficult to understand what exactly is causing autism. But when we are calling it as a spectrum, it means they have a wide range of symptoms, and you cannot see the same symptoms in another autistic child. So the range of symptoms is so wide that it is not present from it varies from one individual to another individual, and that is why we're calling it as a spectrum. And because to avoid all the confusion, previously we used to call as autism, childhood autism, and all these used to come under neurodevelopmental disorders. And we used to include another conditions like autism, then Asperger's, then Fragile X, then Retters, all these things that we used to classify, but we have taken all those things and now we are labeling all those disorders under one thing, that is autism spectrum, to avoid the confusion. So if you look at the statistics, according to the CDC, USA, now about 1 in 36 children have been identified with autism spectrum disorder. And it is reported to occur in all racial, ethnic, and socioeconomic groups. When I was practicing in UK, they used to call autism as a disorder of the upper class society. But I think that situation has gone now and it is seen everywhere. But on a comparative note, it is more on the urban side rather than the rural areas. Again, when we are looking at the autism, it is more common in boys than the girls. Now, again, they are saying about 1 in 6 children aged between 3 to 17 years were diagnosed with a developmental disability, which includes mostly ASD, ADHD, blindness, cerebral palsy, which are taking the lead among these neurodevelopmental disorders. So what exactly, what is the cause of, because when I see patients in my clinic every day, the first question the mother keeps to me is like, why did my child develop autism? For me, it is so difficult to answer this question because even though there's so much of research is happening in this field, we are still unable to find out what exactly is causing the autism. Even though there is so much of research to say that it is mostly an interplay between genetic and environmental factors, till now we are unable to exactly pinpoint or figure out what exactly is happening. So there are few things like, because it could be, as I said, genetic or environmental contribution, or if the mother is having any problems during her pregnancy, that is prenatal, perinatal, and postnatal, or if the child is having any brain abnormalities, like while during birth, if the child is having any, hydromegaly or microcephalus or any meningitis, any problems with brain during birth, or if the mother is not having any proper nutrition during her pregnancy, or if there is any inflammatory diet, because there were some associations with, because a lot of kids with autism will have issues with gut problems as well. So inflammatory diet, there is so much research is going on there, and also hereditary and chromosomal abnormalities. Previously, initially, when a decade back, they were thinking it is most 99% it could be hereditary. But now I think because so many other things are taking in, now the hereditary part is coming only up to 90%, taking the other things into consideration. So, so there is no one cause of autism, just as there is no one type of autism. So you can see, sometimes initially, even when I started my practice, even I used to wonder, like, when I give a diagnosis to a child, I used to think like, these are the symptoms I saw in the child, but these symptoms are not there in this other child. Should I label the child as an autistic or not? So I had this confusion when I initially started my practice as well. But later I have seen so many people, like, because with varied presentation, so sometimes you have to be really very expert in giving a diagnosis of the autism, because it is going to affect the child as well as the family. So mainly we are thinking it is the genes, the environmental factors, and the interplay between the genetic and environmental factors could be the leading cause of autism. So what is that we are thinking about autism spectrum disorder now? Now it is also considered as a behavioral syndrome, because most of the whenever we go out or whenever we see a child, we are seeing it with so much of behavioral issues in the child. You can say, I mean, without talking him or anything, just looking at the child, you can say the child is having autism spectrum because of the various behavioral issues he exhibits in that few minutes of time. As I said, there are multiple etiologies like genetic and environment. And the other thing what they're saying is autism is a lifelong condition. I know it is like, very painful to hear this for most of the parents, but they have to accept the fact that it could be, in most of the cases, it is a lifelong disorder. And there could be, they can appear different, because most of the patients whom I see in the clinic, they'll ask me, look, does my child look normal to you, madam? Does he look as an autistic child, or does he look different from other kids? And these questions are very difficult to answer. Unless there is, I would say, I think Dr. Sandhya will know about all these things, different appearance in, I suppose, like if there are any other genetic conditions associated with those things, then there might be some difference in the appearance. But usually I don't find much difference in the appearance of kids with autism and without autism, unless there is a real genetic condition or some chromosomal abnormalities or genetic syndromes are associated with the kids. And the importance of early diagnosis, because even now whenever I see some patients coming from rural areas, they say, like, why did you take so long to come and see me? The first thing they say is, because my in-law said, like, it is a male child, and even we didn't speak until age 4 or 5. So that's what my mother-in-law or my mother has been saying this, that's why it took so long time. So please, that's the not to consider that anymore. Whenever you feel that your child is not behaving, like, even though if there is any slight deviation from his normality, I think that is the time you have to bring the child to the specialist. And also need for a sustained support in every aspect. I would say it is not only like from the management, financial, from the moral, from the psychological, from the society. I think that support is needed for every child whoever gets the diagnosis of ASD. And also there could be, I mean, again, when we say autism, there are different levels, like mild, moderate, severe. In severe, there is a greater impairment in the social interactions. So all these things have to be considered, and this is the current concept of the ASD. So I've been saying ASD for a while now. So what exactly is autism? When do we give a diagnosis of autism spectrum? So we are looking in the 3 main domains. Okay, the first domain is the speech and language delay, where the mother will say, my child he's already 2 or he's already 3 years old, but he's not saying mama or papa or anything, but occasionally, once in a while, he might say mother. Sometimes he calls his dad, or sometimes he calls his siblings, but it is not on a regular basis. And he doesn't ask for food, he doesn't do anything. Or sometimes he enjoys watching television. Whenever there is a good rhyme or a cartoon coming in the television, he comes running around, he watches it. So mother will be, under a lot of confusion, saying that what exactly is happening to my child. So there will be a significant speech and language delay. Actually, usually we expect kids to start saying few words, like at least few words in the sense mama, papa, dada, tata, all these things at least by first birthday. And then by 2 years, we expect them to say at least 200 single words. If we don't see any of those things, then you have to really worry that there is something wrong, and that's the time where you have to see a specialist. And the second thing is communication delay and social reciprocity. What exactly this means? The child doesn't, when we are trying to communicate, when we try to call him, he doesn't respond to the name call, or he doesn't make any eye contact. But if he wants something, he'll come to you. Either he'll try to drag you, or he'll try to point at things. So he tries to communicate not in a normal way, but I mean, not in a normal way, in the sense not through verbally, but he tries to communicate through a non-verbal means, through gestures. Gestures in the sense like dragging, pointing, either asking he shows his hands or he raises his hands to pick him up. Or in some kids who are severely autistic, they'll just cry to express their needs. So this will be like, this kind of presentation is seen, and then we call it as a communication and social reciprocity delays. And the last one is the behaviors. In this, again, there is a wide range of behaviors that you can see in autistic kids. But what we mean repetitive means the child will be doing the same thing again and again. They can do at least for a couple of hours or 3 hours, and the mother will get really annoyed, like, how can a child can play the same game or a same behavior. The most common things that I hear is like, the child will try pouring water from one glass to another, or like, trying to play with a single toy throughout the day or for few hours. And restricted interest, that means the child will show only interest in few things. For the remaining things, he doesn't even listen to, or he doesn't appear as though he's interested in listening to. So this is another area where parents really complain, like, why does the child behave like that? So we will go a little bit detail into all these things. Coming to the social communication interaction, as I said, they doesn't respond to the name call. Which happens by 9 months. If they don't respond, then you have to raise a red flag. And the child doesn't show any expressions. When the mother tries, usually mother will be the first port of call to see or to enjoy the expressions shared by the child. But there won't be any expressions when the mother tries to communicate, or sing some lullabies, or try to tickle with the child, or try to play peekaboo with the child. The mother doesn't notice much of the facial expressions, but sometimes he might express those things, and sometimes he might not. So the mother will be in a confused state, saying that why it happens only at times, not all the times. And also the child might not show any interactive games like pat a cake by 12 months, or very few gestures by 12 months of age, like that is not waving or not saying goodbye. And he doesn't show or doesn't share any interest by 15 months of age. The mother will say, like, when we go to our cousin's place, when they have other kids, my child doesn't like to go and sit with them. Or he doesn't when they're playing also, he's least bothered, he'll just go to other corner. If they're playing in one corner, he'll go to the other corner. Or he doesn't or otherwise what he'll do is he just cling to his mother. He doesn't even get down to go and meet the other kids playing around. So the other thing is not pointing to show you something interesting. This what is called as a joint sensation. So if you try to show something interesting, I mean, for example, if you're traveling on a road, if you see something interesting, like, the child doesn't show. The most common example is like, during nights, the mother will show the moon, or, she'll show the dog, or she'll show something. But the child doesn't seem to show any interest to see what exactly the mother is trying to say. And he also if the mother is hurt, if the mother is upset, if the mother is crying, he doesn't show any interest, or he doesn't pay any interest to the emotions of the mother. And there won't be any social play, like, most of the parents, I recommend them to go to the to join their kids in the play school as early as possible, at least by 2 years of age. But the mothers keep coming back and tell me that, even though we are trying our best to send the child to the play school, but he's playing on his own, he doesn't mingle with any other kids. Sometimes he might go and sit with the teacher, but he doesn't mingle with the other kids. That's also another common things which I hear. And pretend play also we check on a regular basis. This also, like, usually we notice this in the girls, when they start going to the school or nursery or play, they come back and they pretend play, either in front of their brothers and sisters, like they're acting like a teacher. But there won't be any pretend play by 4 years, and they might not be able to sing or dance by 5 years. So these are like, few red flags that I have mentioned here. So if the child doesn't notice any of those things, then you have to, I mean, so here what I'm saying is by 9 months, the child will be having the red flags, and the families or the parents should keep a watch on all these things. And there are so many websites available to see, like, what are the developmental milestones. So what I request all my patients is to take a printout of the milestones, and then regularly monitor how your child is doing, and to see if the child is not responding, or like, not, if there is a significant, or if there is any delay in the milestones, then they have to see their specialist. So the other thing is restricted and repetitive behaviors. Here, the most common thing again, I mean, I've mentioned the most common things which I see in my clinical practice, even though there are so many other behaviors which are listed, because the list goes on, and I can't keep all the list here. So I've just picked a few important ones. So the lining up of toys, the kids tries to arrange everything in a line, whether they take the kitchen objects or whether they take the toys, they try to align them in a line. If you try to change it, the kid will get really upset. And in some kids, there might be some amount of speech, like, they repeat the same things. Like if you ask him, what is your name? The child will say, what is your name? And we call it as a classic echolalia. And also, as I said, they try to play with the same toy every time. And they also focus on particular objects, like, usually balls, and also wheels of the car, or wheels of any trucks or bus or anything. They focus, their focus goes on those round objects or rotating wheels. And most of the parents also complain that, not only these things, they start examining their cars tires or the bus tires when they go out as well. And they get upset by the minor changes, because autistic kids don't like changing. So they want everything to be placed in a particular order. How they place the things in an order, similarly, they want their life to be arranged in a very systematic way. If there is slight delay in their routine or schedule, they get upset. And they have obsessive interest. And also they follow certain routines, what we call as rigid routines. That means if they are going out at a particular day, they would expect to go, or they expect their parents to take out on the same time every day. So flapping hands, rocking the body, spinning self in circles, or pacing around the rooms, or another very commonly seen repetitive behaviors in autistic kids. And not to forget the sensory issues, like, touch, taste, smell, and sounds. And they behave differently when all these things are in place. So apart from these three things, there are other common associations. Apart from the speech, there will be delay cognitive or learning skills. So in most of the patients, whenever I give a diagnosis of autism spectrum, we have to rule out other two common conditions, that is developmental delay, which the presentation will be similar to autism, but the development will be an entire aspect. But in autism, it will be only three aspects. But when we give a developmental delay, that there will be a complete or a developmental delay of the milestones, and also learning skills. And the other most common association with ASD is, apart from intellectual disability, it is attention deficit hyperactivity disorder as well. And other most common thing not to forget is epilepsy or seizures. Most of the kids will have epilepsy. If the child had any epilepsy during the first month of their life, they'll be obviously placed on the anti-epileptics. There is a research to say that, if any usage of anti-epileptics during childhood could also a potential risk factor for developing autism spectrum. And they'll have very unusual eating habits and sleeping habits. When I say sleeping habits, the mother will say, like, they have significant sleep issues with the child, and sometimes the child doesn't sleep or sleeps for a few hours, and again he gets up and then he cries for some time, and the parents doesn't know how to handle that child. Mostly in UK, what they do is they put the child in the child booster seat. So that's how they put the baby to sleep, and they bring back to home. So they'll have significant sleeping issues, and the eating pattern is also very different in those kids, because they eat very spicy or they eat very bland, and they eat only same type of food what they tend to eat every day. And other, not to miss, the gastrointestinal issues, mostly constipation. Mother will say that the child has, even though how much, because obviously, as I'm saying, because they're sleeping, because of the sleep habits, because of the unusual eating patterns, there is a significant problem. That is affecting the gastrointestinal system. That could be the reason for the constipation in the child. And there will be unusual mood and emotional reactions as well, because the mood of the child also varies significantly. Another common complaint what patients tell me is like, most of the things that my child does depends on his mood. If he's in a happy mood, we can engage with him, or we can interact with him, or we can teach him. But when he's not in a mood, it's very difficult for us even to handle the child. He expects us to leave him to be on his own, so that he plays with his own toys and he doesn't like to be disturbed. And other common associations are anxiety, stress, and excessive worry. Because whenever there is a slight change in the routine, the kids get really anxious, and they try to cling to their mother. These things happen when they take the child to the any social functions. This type of behavior is noticed, and in some kids, usually they say the autistic kids, they lack fear, or sometimes in some patients they say like, it is on the opposite side. So these are the other most common associations which are seen in most of the autistic kids as well. So I think the parents have to really understand that there are two different things in autism. One is a tantrum and one is a meltdown. Because I think nowadays we are seeing a lot of grandchildren left with the grandparents, because the parents are not able to handle the kids of various reasons, whether they are working, whether they are not having time, or whether they are staying abroad. So what happens is there is a lot of pampering from the grandparents. So when there is a lot of pampering, the child will always try to take advantage of this. Not only to blame the grandparents, even when the parents are like, if it is a first child, they try to pamper the child for every aspect. So whatever they want, they'll just give it. So the child will go into that behavior like, okay, if I throw a tantrum, or if I cry for some time, my parents or my grandparents are going to give it to me. So what he does is he tries to throw a tantrum whenever they say no. But in a meltdown, which is a typical of autism, here the child will have a reaction without any trigger. And when he gets into that meltdown in that reaction, it is very difficult to handle the child. The child will be very irritable. You cannot handle the child. The child might cry for few minutes. It can be anytime, from 5 minutes to half an hour. And irrespective of the surroundings, the child will express the meltdown. But whereas in case of a tantrum, the child will throw the tantrum only when you say no, or when you don't give him what he wants, then only he'll place the tantrum. And also the severity or the intensity of the tantrum depends on the how you are observing the child. If you are looking at the child head to the floor or to the wall very gently, so that he doesn't get hurt. But whereas in a meltdown, irrespective of the people, irrespective of the surroundings, irrespective of anything, he'll just have his meltdown. And the reaction can be so severe, anywhere from 5 minutes to 30 minutes, and he can have the meltdown. So you have to clearly understand what is meltdown and what is tantrum. And tantrums can be easily handled. If you just ignore the child and leave the child there, then you can easily get over the tantrum, but not the meltdown. So coming to that treatment aspect, we all know that there is no medication as such for autism spectrum. But if the child is having severe behavioral issues, we try to control them by giving a small dose of an antipsychotic. But if there is any significant socialization issues, if the child is having a lot of fear, a lot of anxiety, we try to treat him by giving a small amount of an antidepressant or an anti-anxiety medication to reduce his anxiety. But overall, we don't have any medication so far. So what we think is, whenever you identify or whenever you recognize the child that he is started exhibiting the symptoms of autism spectrum, we advise the parents to start these therapies. And these therapies are basically the cognitive training. They help the child to start think, how to play, how to develop those skills that are required. So in these therapies, the applied behavior analysis plays the most crucial role, but unfortunately, this is not properly available in India because ABA therapy is certified from abroad, and unfortunately, this ABA is not available in India. So ABA in Hyderabad, you can hardly count on fingers. A few of them, not even few. I think I can name them, or 4 or 5, who has got this certified because they went abroad and they got trained there. It's a year of 2 year certificate course, but in my experience, ABA works really well for kids because they help in you know. They implement and maintaining behaviors like self-control, eye contact, sitting tolerance, and also teaching them to transfer learned behaviors to new environments, modifying the learning environment to challenge them in certain scenarios, and also the reducing the negative behaviors like self-harming and self-talk. Uh, so ABA is the most important therapy, and this is modified in India as a behavioral therapy, and this is started once we diagnose the child and we send to the therapist. And second one is occupational therapy. This is again which help them to for maintaining their activities of daily living, like brushing their teeth, using the toilet or toilet training, or perceptual skills such as to tell difference between colors and shapes, problem solving skills, play, communication, social skills, or fine motor, gross motor, all these things, and sensory issues will be handled in the occupational therapy. I mean, most of the parents know about all those things, so I'm not going to spend much of time. And the other thing is the speech and language therapy. This is to address the challenges in the languages and communication. So basically, what the speech therapist says, because the muscles of the mouth are not strengthened, so that could be the reason why the child is not able to say or make any speech or language. So the therapist will help in strengthening the muscles, make them help to make clear sounds, match the emotions with the correct facial expressions, understanding the body language, responding to questions. The other thing is most important is matching a picture with its meaning and also modulating the tone of voice. So this is what a speech therapy exactly does when they start the speech therapy. So I think this is the most important for the parental management. So first of all, in step one, what I would request all the parents is, first of all, you have to know your child's triggers. What is that making your child upset? And in the second step, you have to understand how should we communicate to the child so that he is less stressed and he doesn't and he has a proper day. Because most of the parents say, like, some days my kid is very good and some days my kid is very difficult to handle. So it all depends on how we communicate with the child. So I think that is also a very important aspect. And the last one is the practicing 3 R's, which I'm going to discuss in my next few slides. So in the step one, first of all, you have to identify what are the early warning signs, or what is it triggering the situation. Why the child is behaving differently today. Okay, so if you look at the biological triggers, if the child has difficulties with communication, so he might not express his needs, he might be thirsty, he might be hungry, or he might use that he wants to go for a toilet, or he wants to if there is any hormonal imbalances in the body, if there is pain in the body, or if he's got hurt, so he cannot express any of these things. So you have to always think in these always these things should come first, and then you have to see, is this the reason why the child is becoming irritable or agitated? Is this the reason why he is becoming withdrawal? Is this the reason why he's throwing a tantrum, why his expressions are changing? And there could be some physiological signs and then some behavioral changes. So what I request every mother to carry initially a diary, so that they can write down all these symptoms, what the child is expressing whenever he's getting upset, what is happening before the child is behaving such way, and what is that, how is the child behaving once we address that issue. So this piece of information will give you a lot of information how to handle your child in future. So the most important thing is you have to identify the trigger, why the child is becoming different all of a sudden. In step 2 management, you have to also identify if there are any environmental, because most of the parents will say my child is absolutely fine, doctor, he's behaving only when we have come to you to show my child, but this is not how the child behaves at home. So what is that means is the child is finding difficulty with the transition of the climate, because he is able to um, stay happily in his house, but when he comes outside or when he comes to a different place, he's having that difficulty. The transition is making also difficulty. Or climatic, I mean this I mean based on the temperatures, based on the weather conditions also, they say there could be some trigger, because in western countries there is a lot of temperature variations, and they say like all those things can also affect the child's mood and sensitivity, because in autism there is a lot of sensory issues. And when we say sensory issues, it could be hypersensitivity or hyposensitivity. So some kids, like they may behave normally, but by the evening when you start switching on the lights, or if there is a hyposensitivity or hypersensitivity, the child will take some time to get used to the light when we switch on in the evening. Or if there is any change in the daily routine, because he is so used to the routine, but if they have to go to a different place for any function, or any for any religious places, if they visit, the child will have difficulty in getting adjusted to this new place or new lifestyle. So they all come under the environmental triggers. If you feel that the child is having these difficulties, then it is advised not, I mean, I won't say not completely avoid, but you have to gradually allow the child to transit by not going to very far off places, initially to plan for few hours, and then gradually you have to increase to a day or two, but not straight away. And the social triggers, these are like when the child starts its play school or nursery or mainstream school, because not all the children will be diagnosed only in the very initial stages. Even yesterday I've seen a kid who was like 4.9, and he came to me for the first time. When I asked them, they said like my mother-in-law said like his father spoke at around 5, so that's the reason I didn't bring the child to you. So he's already going to the school, but he's going to the school, he doesn't mingle with anyone, he'll just sit there, because he's been going for the last 1.5 years. So he just goes there because he got used to the routine. So he's going there, but he doesn't do anything. He doesn't even open his books, or he doesn't play. He just goes there, sits, and come back. And the reason, because nobody knows what exactly happens, because and then that could be he might have bullied from his friends or relatives. That's the reason why he's maintaining quiet. And they also become a little bit more unpredictable when you take to a crowded places, or if they have to face any challenging social situations. So you have to look for the social triggers. And finally, the psychological triggers, mostly if there is any new person coming to the house, or if they see any new people when they go outside, if there is any excessive fear, or if there's any tiredness due to lack of sleep, and any comorbid mental conditions, which are mostly anxiety. So these also trigger that trigger and affect the child's behavior. So all these things you have to take into consideration when there is a change in the routine. And the second one is like, how you communicate with the child. I mean, because I see in my clinic, because sometimes the kids will, the parents will be shouting at the kid. I mean, I can understand, like, they're seeing the child every day and they're finding it hard because some mothers doesn't have any support. So is there any problem?
No.
So I think how we communicate with the child is also very important here. I mean, there are a few examples here which I mentioned, like, for example, rather than mother shouting on the child, like, keep quiet, we can say, like, can we speak softly? So the communication of the mother or whoever is the looking after the child, their communication should be very gentle. Otherwise, it will be very difficult for the child, because or otherwise some mothers, like some grandmothers, will be talking continuously, and an autistic child will find it extremely difficult to handle so much of language. Rather, what we say is, like, you use only few sentences, and also, like, mostly use single words so that the child can can develop some reception to the language. And the step 3 is, like, 3 R's, which I was mentioning before. It is regulation, relating, and reasoning. So all these things. So when regulate means during a meltdown, you have to really be calm. You have to, there should be a lot of caring, loving the child during the meltdown. And you have to validate and reassure the child. And you also should make that you are well connected to the child. And reasoning is to correct the appropriate behaviors and preach the appropriate alternatives. If the child is behaving in a certain particular way and you think that, you feel that it is an abnormal, then you have to correct the child by teaching a proper normal behavior. So an example here is how you regulate your emotions. For example, if the child see, like, staying calm as an adult, as which I was mentioning here, staying calm as an adult when dealing with the child with an escalated situation, rather than you also losing the control, and rather than shouting at the child, why are you crying for so long, you have to maintain that calm posture. And also you can be more affectionate by just holding the child. Okay. And also use some visual assistance by distracting the child by blowing the bubbles or blowing the candles, or smelling the food or flowers. So what I'm trying to say is, like, when the child is upset, don't try to get anxious, or don't try to get overwhelmed. Just take a step back, relax, and then just hold your child, and then start thinking what is the best thing you can do to control the child. But don't lose your so how you relate, how you like the ways to help the child feel connected with you. I mean, sometimes the child find it extremely difficult to understand your emotions as well. Some kids can understand when you raise a voice, the child will feel, okay, this is something which is not the normal voice which I'm hearing from my mom. There is some difference in the voice intonation. So if you raise your voice, the child will understand. For severe autistic kids, it is also difficult to identify that change in intonation of your volume of your voice. So what you can do is, you can show some cards where, like, to understand, for them to understand what expressions or what emotions you are going through. So there are a lot of cards available in the market where you can show the child, so that they understand that whether you're happy, whether you're angry, or to sad, all these emotions. And finally, reasoning. As I said, like, if you think the child is having difficult behavior, please change that to a other alternative behavior which is helpful for the child. Because most commonly the parents will be saying that, teacher complained that your child has pushed another child, or the child has pinched another child, because these are the common behaviors you see. So what you can teach the child is, instead of pushing or hurting the other child, you can teach your child to hug the other child. So you're replacing the abnormal behavior with a normal behavior. So finally, what I would say is, when you're having an autistic kid, stop looking for a cure and stop striving for the normality, because most of the parents will be saying, like, when they come for the repeated follow reviews, they say, madam, how long we are going to take, when is my child going to get normal, how long I have to continue this therapies, I feel my child has come back to normalcy, can I send him to mainstream school? So there will be a lot of questions, like, but always what I would say is, like, you don't need a specialist or someone to say, like, whether child has completely come back to normal or not. A mother instinct will tell you. So always have some patience, and don't always expect that, tomorrow my son is going to get better, day after is going to, don't keep any time frames. Let it happen, and try to always understand your child more than looking for the normalcy. So autism can't define me, only I can define autism. This is a famous quotation said by Dr. Kerry Margo. And with this quotation, I would like to end my talk. I think I have taken a little bit longer time. And thank you, everyone. Thank you for being patient and listening to my lecture. Thank you so much. Hello.
Thank you so much, Dr. Nandini.
Dr. Nandini, it is an excellent talk, very elaborative, very explaining everything, every aspect, both for the children and also the parents and the other society who are other groups who are involved in taking care of the autism children. We thank you very much for your patient and elaborate
Informative.
Yeah, I'm so sorry. I think I've gone, I've taken too much of time. I think I got just involved into it.
We are to so involved with this, no? That shows your involvement in this problem. I thank you very much on behalf of Genome Foundation. And Genome Foundation is always there to help in providing counseling and also in providing whatever help, either the diagnostics or clinical or in counseling. All of you will be there supporting the Genome Foundation to support the children suffering from autism disorders. Thank you very much, sir. Thank you
Thank
very
you.
much, sir, Nandini.
Thank
Okay.
you. Thank you.
Thank you. You please wait for any queries and
Yeah, sure.
doubts from the
Audience.
audience. Okay, thank you. Now I request Dr. Aaron. Aaron is there, Dr. Aaron?
Yes, ma'am.
Yeah. Welcome to this first webinar, which is the first in the webinar series on autism to help children. So I just introduced Dr. Aaron, who is associated recently. She is associated with Genome Foundation. We are very grateful and thankful for her, help and her interest in providing whatever help is needed for by Genome Foundation. She is actually currently she is in the Department of Clinical Research, KIMS Icon Hospital, situated in Visakhapatnam. She is a PhD. She is a PhD from Department of Human Genetics, Andhra University, Visakhapatnam, and MPhil also from Human Genetics Department from Andhra University, MS in Molecular Genetics from Department of Human Genetics, Andhra University, and her graduation in Biology, Biotechnology, Biochemistry, and Chemistry. Her PhD title is Polymorphisms in Glutathione Transferases. She is having a lot of experience in academic experience and also research experience. She is a pre-PhD fellow in the Molecular Genetics Laboratory of Professor Gaddaya Gangisetti on genetics of psoriasis and vitiligo up to 2009. Up to 2017, she is a senior research fellow at the Department of Human Genetics, Andhra University. She is having extensive teaching experience also. From 2013 to 2017, she rendered teaching assistance to postgraduate students in biotechnology and human genetics at Andhra University. She is having very good laboratory experience related to genetics like cell culture, chromosome preparation, and banding techniques for fish isolation of DNA and RNA from various tissues, DNA sequencing, PCR, gel electrophoresis, polymorphism detection, real-time PCR, handling patient medical data and research activities, patient data management using Microsoft Internet Access Linux expert. She is a medical licensed scientist, board certified genetic counselor, crucial member of the NABL accreditation team for molecular biology lab in KIMS Icon. And she formed the Institutional Ethics Committee at Visakhapatnam KIMS Hospital. She served as an EC member and also as clinical research specialist, genetic consultant, oncogenetics, rare genetic disorders. She, her experience is in breakthrough genomics, Southern California, product licensing scientist for Asia, Middle East, clinical research head, molecular biology scientist and genetic consultant at KIMS Icon, and also research administrator at KIMS Icon, Visakhapatnam. She established professional relationships with and she builds to build advocacy and scientific partnerships with KOLs and decision makers. She is very active in participating in generation of comprehensive, articulated and impactful programs, including education, scientific communication, evidence generation tactics, and customer internal and external collaboration. She can deliver unbiased and accurate scientific and clinical presentations to HCPs and KOLs individually or in groups. She gathers medical insights and supports the translation of those into development and commercial product strategy. She acts as an educational resource to internal stakeholders. She supports the sales force and also other departments with medical science information. She acts as a subject matter expert for external clinical scientific stakeholders. She collaborates and contributes significantly across those disciplines and also to foster overall interdisciplinary research and training to our scientists. She develops operating procedures and also ensures that the entire research team follows those procedures. She creates good overall guidelines for clinical research and ensures that the guidelines are followed. She balances the budgets and also oversees the management of the clinical research. She has a lot to for her credit and she is a project manager at Actimus Bioscience Phase 1 clinical research and also she served the BioServe and also she for her credit she has published many articles in international journals and also delivered many lectures in many international and national conferences. She is a medical licensed scientist in external environment and customer focus. She effectively presents information to HCPs and be able to respond to questions, ensuring medical accuracy and compliance with local procedures, ethical and legal guidelines, and directives.
Ma'am, that's
So,
okay. I think that's enough, ma'am. No, ma'am.
so
I think we have a
because
very
of
short
the
time.
paucity of time, I'm not able to completely.
No, ma'am. Sorry, I think that's too lengthy.
So let us hear her experience and also her various clinical experience and also various genetic experience in autism spectrum disorder. Dr. Aran, we are
Yes,
very
ma'am.
lucky to have you in our team in Genome Foundation, and I request you to start your talk.
Thank you, ma'am. Hello, everybody, and I think that was a very long introduction. Am I sharing it right, Gargi, or
Ma'am,
do I
can you
have
make
to?
it full screen, ma'am?
Yeah, that's what I'm saying, where the option is.
On your Google slide,
Yeah.
yeah, open with Google
Okay.
Slides, ma'am. Yeah,
Did you get that? Yeah. No?
not yet, ma'am. No, no.
Okay. I should open it with
Yeah, it says open with Google Slides.
1 second. It's asking window. Is that correct?
You can try the window option, ma'am, if your PPT is already open. So it should
Yeah,
be
it is
allowing you
open.
in that. Yeah, yeah. Window, and then they should give you the PPT option. Uh,
Yeah,
yeah. It's still
open a
coming
new
that
window.
much only. Okay, I
Yeah,
think
it's
it
still
should be
coming.
fine, ma'am.
Okay,
It's
yeah,
okay,
thank
ma'am.
you.
Let's start.
Yeah, so genetic basis of autism. I think Dr. Nandini delivered a really excellent talk on the phenotypes and the various aspects of autism, the clinical and the phenotypic presentation, and a little bit of treatment and all of that. So now coming into the genetic basis of autism spectrum disorder is really very important because this tells us the strong genetic component underlying this spectral disorder. So I will straight away get into some details from the recent research findings to understand how we authenticate genetics being, one of the factors contributing to autism. So, how do we know that genes really contribute to autism? This happened in 1977, where the first twin study they compared the autism rates, and they have showed that it is highly, highly heritable, which is one of the major research findings. So, when one identical twin has autism, so three in about an 80% chance that the other twin will have it too. So, corresponding rate for fraternal twins is around 40%. This happened in 1977, and there are several conditions associated with autism that stem from mutations in single gene, which is the most talked about, including Fragile X and Rett syndromes. But less than 1% of non-syndromic cases of autism stem from mutations in any single gene. Coming to the largest study to date, published in 2019, we can say probably that is one of the largest and the most recent, involving about 18,000 autistic and 27,000 non autistic people. And this study really revealed that 12 regions of the genome harbor autism linked common variant. And the two additional regions turned up in a 2020 reanalysis of the same data along with about 6,000 extra additional samples. So this shows a strong correlation or relation to the genetic component. Now, coming to autism spectrum and the genetic architecture, we see that ASD-related syndromes contribute to 10%, in which Fragile X is there for area. Rare chromosomal abnormalities contribute 5%, like the maternal 15q11 chromosome duplication and trisomy 21, 45X, and Turner's syndrome. And very, very rare CNV's etiological gene, not yet totally defined, contribute about 5%. And we also have another segment called rare penetrant genes. So these multigenic contributions include rare or common variation and the intellectual disability and neuropsychiatric disorder genes. So genes in common pathways, example like the synapse genes to ASD risk genes, the contribution is still not very clear, but aggressive research is going on. And even sometimes the maternal age is also considered as a factor for some kind of error in the cell division. Now, we also have karyotype studies, and the very, very early karyotype studies, the chromosomal studies, documented some chromosomal abnormalities. And this is where it started to throw some light on regions of genome, which regions of genome were involved. This happened in 1985. So I'm just giving you a gist of what has happened in research and how it is assisting us to understand the genetics contribution to ASD, and which will this further help in treatment development, in developing effective treatments and diagnostics. Now, coming to multiple studies have found an increased de novo mutation in regulatory elements of ASD risk genes in 2018, 16, 17, and 18. 2018. So the broad class of susceptibility genes, this will be too technical if I read out the names of the genes, but just to know that, such, what do you say, breakthrough research is happening across the world. So chromatin remodeling pathways, including MECP2, UB3A, and the DNA binding protein CHT8, and dependent neuroprotector homobox ADNP, were derived with ZNF domain, fragile X mental retardation, FMRP, and RNA binding pork head box. That is about the early karyotype studies. And coming to CNVs that contribute, CNVs are nothing but the copy number variants, which contribute to ASD susceptibility. Now, studies have found a higher load of rare genetic CNVs in autistic individuals, implicating that these variants in ASD pathology. This happened in 7, 10, and 19. Now, CNV is now understood as an extremely important contributing factor. Until very recently, CNVs were not in the picture at all. It was either the chromosomal analysis or trying to find out the single genes. But now CNVs is an important contributing factor, and the current estimates postulate that these variations, they directly cause roughly 10% of ASD cases. This happened in 2011. Now we have like various studies, research summaries from 13 twin studies and 17 heritability studies. So I think this graph shows that it is hard for us to read now. And we also have genetic studies on autism from 75 to 2015. Identification of candidate ASD risk genes happened in 1977, in the very first time in 1977. And the incidence among siblings was 50x higher than the average. And these were conducted twin studies in 1977. So they found that monozygotic twins were more likely to share a diagnosis than dizygotic twins, suggesting a strong genetic influence in monozygotic twins who share the same genome. And Bailey in 1995 supported this finding, and he gave a certain percentage of concordance, that is 60% for monozygotic twins, and versus no concordant dizygotic pairs. Now, in addition to this, risk of child having ASD was found to be proportional to the percentage of genome they shared with the affected sibling or parent. Now, that is a very important finding. And clinical implications, and what next? What will this really be helpful to parents suffering and children suffering from this kind of spectral disorder, which cannot be defined or which cannot be filtered or boiled down to one particular diagnostic factor, be it environmental or genetic or biochemical markers, etc. However, the clinical implications and future perspectives hold a really strong, a strong hand to us. They give us a strong support that yes, something is happening towards understanding the clinical the clinical heterogeneity and the genetic heterogeneity in this particular disorder. So when autism was first described, it was hypothesized to be only environmental, but now we understand that it is not environmental only, but it has several factors in which genetics is one of the key players in contributing to the ASD. Now, after decades of research, it has been revealed that autism is highly heterogeneous. As I told you, sometimes the phenotypic heterogeneity, the clinical heterogeneity, and genetic heterogeneity, both are involved. And it is a complex, extremely complex genetic condition. Even though great progress has been made in identifying hundreds of risk genes, we are still trying to find out the different types of modifiers that may, exacerbate disease severity. So such modifiers, what are such modifiers? Why should we know? This is because this will help us to understand the disease better, the diagnosis better, and the treatment better, to have a better life for children suffering from this. And what can be done to understand or diagnose prenatally, or even before, when a couple comes for counseling, to ask if they are at a risk or predisposition of having an autistic child. We cannot, as of now, be very certain, but progress is being made towards such kinds of research. And now, so the modifiers include epigenetics, sex-linked modifiers, copy number variants, double hit mutations, or environmental factors. Now, due to the extremely diverse genetic phenotype of patients, we see mild, moderate, severe, we see gradings giving to them. We categorize or we grade the child based on the severity of the phenotype. Now, in such cases, personalized medicine may be a future avenue. Why all this research? Some parents directly ask us, do you think something good comes out of this research? And we promisingly tell them that yes, your contribution towards research will help us to devise better diagnosis and better treatment and better tools for this condition. Now, so future of effective treatment, a condensed series of genetic tests such as microarray now, which is, is one of the groundbreaking genetic diagnostic technologies to understand and identify the risk loci, could be an expedient and cost-effective solution to determining genetic etiology. Alternatively, therapies uh, are developed based on the genetic mutations or the alterations that happen in the genome, which can be like more of targeted therapies to address these disease phenotypes and the multiple genetic etiologies. So, such as neuronal hyperexcitability, abnormal synaptic function, but continued investigation will be eventually lead to a cohesive understanding of the interplay between causative genetic factors and disease modifiers. So this is not so easy as we talk, and there is a lot of support and contribution required by multiple functionalities for this to happen in the very soon, in the very near future. Thank you very much. That is in a nutshell about the latest research and contributions. Thank you.
Thank you, Dr. Aaron. Thank you so much for your presentation.
Thank you.
Thank you, Dr. Dharan.
Informative.
You have made it very simple and easy to understand the complicated genetics
Thank you,
involved
ma'am.
in this. Yeah. Please wait for the participants to
Okay.
raise their queries after Dr. Sanjay and Dr. VR finish their talks.
Sure. Sure.
Thank you.
Thank you.
Thank you. Thank you very much. Hello.
Kanak Bhushan ma'am, your camera is
Yeah,
blocked.
yeah. Hello. Yeah. And I'm inviting our Dr. Sancha Annamaneni. She is an assistant professor and chairperson for Department of Genetics, Usmania University. Dr. Sancha, she is working as assistant professor in the Department of Genetics, Usmania University since 2013. She has obtained her PhD in genetics in 2011 and MSc in 2003 from Department of Genetics, Usmania University. She is a recipient of ICMR DHR funded long-term international fellowship for young biomedical scientists in 2019-20. As visiting researcher during this tenure, she worked on synthetic lethality-based approaches for metastatic breast and ovarian cancer at Department of Cell Biology and Biochemistry, TTU-HCC, Texas, USA. Before joining as faculty, she worked as academic lecturer in Pragati Degree College for Women. And also she is a visiting scientist at Indian Statistical Institute, Hyderabad, from 2012 to 2013. Recently, she is awarded as Associate Fellow of Telangana Academy of Sciences. She has 16 years of research and 11 years of teaching experience. Her research areas of interest are human molecular genetics and cancer genetics. 2 PhDs are awarded and 48 academic projects were accomplished under her guideship. She is today she is credited with 34 research publications in national and international reputed journals. She has attended several scientific conferences and presented her research work. She has collaborations with various organizations and involved in research projects on medical genetics, conditions like autism and PCOD. Her research focus has been on mutation screening as well as SNP analysis of functional variants of potential targetable genes of involved in chronic myeloid leukemia and breast cancer for assessment of their role in predicting disease risk, progression, and relapse, and also drug resistance. We are very lucky to have all these accomplished scientists and our professors with our project Autism, which we have taken up recently with our under the guidance of our chairman, Dr. P.C. Gandhi, P.C. Kaja. And I request Dr. Sanjay to deliver her lecture and enlighten us with whatever things we can do in autism children by doing diagnostic genetics and also counseling. Dr. Sanjay, please.
Thank you very much for the kind introduction, madam. Am I audible?
Yeah.
Okay, thank you.
Audible.
So, yeah, respected Chairman and Managing Director, Dr. K.C. Gandhi Garu, and Dean Research Genome Foundation, Professor V.R. Rao Garu, Chairperson Kankabhushanam Madam, Convener Gargi, all my team members who are working on the Autism Project and TNBC project, and the audience. A warm good morning to all of you. And first of all, I'm really very glad to be invited to this or being a part of this webinar. And on the auspicious, particularly the Autism Awareness Day, I've been always participating in on April 2nd to take more leads and also give more updates on the autism at several platforms. And today I'm glad here to be present with you all. So, and thank you both the speakers, Dr. Nandini Garu, for covering the clinical aspects of the complex autism spectral phenotype, as well as Dr. Oren, who has covered in a nutshell about the genetic basis of the autism. I'm going to take a few more minutes to reorient the information that has been covered so far and to give more insights into some of the molecular mechanisms that you need to understand in order to really comprehend the information that we have to see or to understand the how the genes are regulating the pathophysiology, so that we can plan some or we can decipher some markers that can help in proper diagnosis and prevention as well as the treatment. So here we go. I want to remember this person, Dr. Leo Kanner, who was the first person to describe autism as a distinct condition. So he was a psychiatrist who was actually taking care of some of the concerns that were raised by the patients coming to him. And he observed that there was some similarity between these patients, and he collectively put all these conditions and named them as autism, described it as autism. So I was just waiting for one of these slides, which I added just a few minutes ago. So none of, we did not come across this information, that is prevalence of autism. It is highly prevalent. Long back in 1943, when it was described, there were very, very few cases because people did not know what is autism. Later, from 1990 onwards, slowly the incidence is going up at an alarming rate. So more than 1% of the population is suffering from autism. And globally, around 62 cases per 10,000 individuals are having this problem. In India, particularly, 1 in 500 people are suffering, and already we have more than 10 million people in India who are having ASD. And in 2012, around 78%, there is an increase in the reported prevalence. And I mean, slowly with the available diagnostic criteria, now more cases are coming up because more cases are being reported, and we are able to tap the information from these cases. So just summing up what we heard just now, first of all, when you consider any condition, so the question that comes to our mind is whether it is genetic or not. Yes. So this particular condition is majorly genetic. But what comes to your mind when I say it is genetic? So all people remember that, yes, if it is genetic, it has to pass on in families from one person to the other person through generations. But this particular condition, if you take, the number of cases with family history are very low, around 3 to 5% only. And it is known to be more complex because of the implication of genetic, epigenetic, non-genetic, and various other factors. So very few cases are known to have Mendelian pattern of inheritance. We all know about the inheritance patterns in human. When you study how a trait is segregating in families, we can clearly see that there is some trend by which we can say it is autosomal recessive, autosomal dominant, or X-linked dominant, and so on. And when you see the families of these cases, which are however few, yes, 50% of these cases showing the trend were found to be autosomal dominant, 25% autosomal recessive. Very few cases, less than 1%, were found to have sporadic nature, that is only in one generation without having any family history. Suddenly new mutations are originating in the onset of this thing. And as Dr. Nandini Garu has said, we have two forms, that is syndromic and non-syndromic, which means ASD symptoms. There are so many symptoms which Madam has described. There are so many symptoms which are not distinct in every patient. There is remarkable heterogeneity in the clinical phenotype. And some of these individuals, they have overlap with some other phenotypes. So there are diseases in which autism is one of the symptoms. So it is not just autism as such, but there are other complications to which are called as syndromic forms. And which compared to syndrome forms, there are majority of non-syndromic forms which account to 75%. These are some of the known syndromes in which you can see Fragile X. 25% of the Fragile X cases have an overlap with autism. You can see Angelman syndrome, 40%. And Sanfilippo syndrome, 90% of the times you will see ASD features. I will not go into the details, but I just want to say that, yes, there are genetic conditions where autism is one of the features. So this indicates, yes, if you can explore these syndromes, we can also decipher or reveal or come across the genes that could be implicated in autism, since it is one of the features. So the complex clinical or genetic etiology of this particular ASD is because of the involvement, as I said, from the genetic background, that is genetic factors, the genetic load, that is because of so many mutations from the onset, that is from the zygotic stage to the complete developmental, all through the developmental changes, you might find so many mutations in the meiotic and the mitotic stages. And these genes, or the effect of these genes, is triggered by other metabolic factors within the cell and intrinsic and extrinsic factors, as well as the environmental components. On top of that, we have what are called as epigenetic, the modifications on the nucleotides of the genome, as well as the histone proteins which actually pad the DNA or protect the DNA. So there could be modifications on the chromatin of the DNA, which can also be having some impact on the autism. However, if you just comprehend the information from genetic, epigenetic, and environmental interactions, they all are known to influence the several developmental pathways. It could be neuronal development, it could be immune pathways. So many developmental pathways are compromised, affecting finally or relating to the abnormal prenatal brain development, and one of which is leading to the autosomal spectral disorders. So in a nutshell, we just understood, yes, it is having a strong genetic component. Now we are very sure that we have strong genetic basis. One lead is from the twin studies and family studies, as Dr. Aaron has told. So we can see the recurrence risk in the families and the siblings, which is around 2 to 8%. And since it is a complex multifactorial condition, the amount of genetic component contributing to the phenotype is also very high. That is called high heritability, so which is in a range of 40 to 80%. And one more evidence is from the cytogenetic studies on a large scale of a lower resolution. When you screen the chromosomes, the stained chromosomes of a human at any stage, you tend to see some abnormalities. By karyotype studies, we can see these abnormalities. So these are some of the evidences marking the cytogenetic abnormalities. However, all these which I discussed, that is Mendelian, single Mendelian inherited conditions, chromosome anomalies, or de novo mutations, all account to only smaller proportions in a range of 3% to only 20%. But majority, the major share is because of multifactorial type. So if you see the picture here, the phenotype of any trait, not just ASD, any trait is because of the influence or the understanding of the crosstalk between so many components at several levels, including the transcriptomics. So I can just say that it is genetically heterogeneous with complex etiology. One more important or striking feature is that, yes, we have so many variants that have been identified in different patients of suffering with ASD. But if you see their spectrum, yes, there are mutations, but they may not show the ASD at all. So on a scale of the spectrum, there could be mutations. Yes, there are mutations, but they are not showing any phenotype at all. At the same time, the same mutation can show extreme severe symptom. So this is really very hard to understand. You have a mutation, then it is supposed to show the phenotype. But why is that we have varying levels of or degree or severities of the phenotype? So yes, there are so many molecular pathways that are implicated at all levels that could be known to be, I mean, of course, if you delineate all the variants, I can place them into some categories or discrete packets, specifically relating to each molecular pathway, mainly the RNA splicing. So this is one important component where we are not able to visualize what is going wrong, because at splicing something is happening in the mini exosomes. There are small minute exons which can be carried or which can be functional within the nucleus, and which are altering several pathways leading to abnormalities. But there are many, but short of time, I will not be detailing on these things. So now, yes, if it has a strong genetic basis, parents keep questioning me this. Not only parents, even clinicians ask me this. Yes, once you know there is a strong genetic basis, you have a lot of evidence. Why is that it is difficult to find the genetic markers for diagnosis? If we have genetic basis, we can easily fish out the genes, right? But why is that we are not able to find? So this is what is termed as missing heritability. So there are so many common mutations in the population whose effects are minor, contributing to the autism. So they all act cumulatively to cause a phenotype. Hence, when we screen, even though we find the mutations which are common to autistic panel and also in the population, we will not be able to make some difference. That's why it is difficult to capture. And hence, there is a need to identify which are the causative mutations which has major effect, which are specific to ASD, common in ASD, and might be very rare in the general population. It's not that they are not in the population, they are there, but more often seen in ASD compared to the population. So this can be considered as a diagnostic panel. So once you identify the diagnostic panel, we need to understand the functional role of these mutations. So how they are causing the pathology is a second complication we are going to have. So we have genetics testing approaches at all levels, right from chromosome level to the high resolution DNA sequence level, which help us give or generate a lot of additional information about the variants involved in ASD. So why it is important for us to go for genetic testing? Why do you need to identify these genes? So one is for diagnosis, proper diagnosis of ASD, early diagnosis of ASD, to guide the management of these cases, because we don't have cure for ASD. We need to manage them. So therapeutically, we don't have any molecules that can cure ASD. There are different types of therapy. So how to guide management? Earlier management is very earlier intervention is very important. So we have to go for testing. We need to have a panel that helps in deciphering or identifying the proper case as pure ASD or something else. And this is how there are several other features where we can benefit the patients, their families, and also we can all give a prediction about how they're going to prognose to a particular available treatment option. And we can also give specialized support well ahead of what, because they're all confused, there is a lot of suffering going on, they're lost. And yes, as scientists, as clinicians, as caregivers, we have to be here to help this autistic people in our society. So we need to detect the ASD genetic overlap so as to tailor the proper treatment options. So at a chromosome level, these are the, I'm not going to read out all the variations, but you can see large proportion of mutation can be deciphered by chromosomal microanalysis. So this is about family studies. If you can tap the resources, particularly if you get an informative family pedigree, okay, wherein more than one individual is affected with ASD, you can do what is called as linkage or mapping to know major causative genes implicated in the trait. The segregation is correlated with the association of the markers that you study in linkage, for linkage. So individually, in the beginning, we have studied some genes. Okay, only one or two genes. Like suppose you take the first pedigree here. Here, the genetic mapping and both the whole exome sequencing was done, wherein they could identify one mutation in this gene, sign 1. It is a causative mutation. Similarly, there is another pedigree here. You can see more than more than one individual is affected, and very prominently they saw that these abnormal these ASD patients, they were having a long mutation, a deletion of 63.8 kb in the SHANK1 gene. And these are other pedigrees where they saw that they had with simple test of just 3,000 rupees, they found that these individuals were having a micro deletions at a particular loci only, that is 16p11.2. And later, now we have, in this past decade, we have been working on the whole genome-wide linkage analysis, where you can see this picture, a chromatogram-like picture, where across all the chromosomes from 1 to 22 and X, there are several indications that these loci are implicated or are associated strongly with the ASD. So the first evidence for linkage was on 15th Q in 1997. It was identified. In 1998, similarly, with the first genome screen was conducted to show that 7q was involved. But now we have a many number of important loci. This is the list of the genes that are loci that are identified by different methods of linkage analysis, both parametric, non-parametric, and many other. So one more important aspect which is not known to many, even geneticists, is parent of origin effects. So particularly people suffering with intellectual disability, you see what is called as differential expression of a mutation, because it depends upon the origin of the parent. If there is a mutation, if it is segregating from parents, it could be from mother or father, right? But the behavior or the expression of this particular mutant allele is different. If it comes from mother, it acts differently. If it comes from father, it acts differently. So the parental origin of the allele or a mutation, how its phenotypic effect is different, we can study in several intellectual disabilities. So the parent, these are together called as parent of origin effects. So these parent of origin effects include what is called as genomic imprinting, transgenerational effects. That means through mother, how it is passing on only from mother, and what the kind of interactive effects that you see from when it is transmitted from mother to offspring. Then mitochondrial DNA defects, then sex chromosomes, and mutational transmission bias. When it is passed on, if you have a heterozygous mutation, that is one allele is normal, one allele is mutant, the cell shows bias in transferring or transmitting the mutation. Sometimes the mutation itself is it is intentionally, selectively favored, or sometimes it is not favored. So there is a transmission bias also. So all these collectively are called as parent of origin effects. So while studying the parent of origin effects, we were able to delineate some important pathways like folate pathway, homocysteine pathway, inflammation pathway, because of the maternal genetic effects. Similarly, mitochondrial, just now I was telling, every cell has mitochondria. Some cells do not have. Some cell have more number of mitochondria. So it all varies. You just see the number of mitochondria because there is a variation, we say heteroplasmy. And people studied the mitochondrial number in different cells in autistic patients also. They saw that in neuronal synapses, the mitochondrial energy, there is a high demand for mitochondrial energy. And if there is a disruption in the supply of energy, yes, brain function can be influenced or compromised. Hence, they try to understand the role of mitochondria and their mutations. Yes, they could find these are the some of the mutations that were identified because of the defects particularly associated with parent of origin effects. And this is one beautiful slide which I collected recently. All multifactorial complex diseases, there is some, I can say there are some rules by which we can say that this is multifactorial. One of the features is that some traits are more common in some gender. Like ASD, if you see, it is 4 times more common in males compared to females. So the common gender is, or the more prevalent is, it is more prevalent in males, right? If it is more prevalent in males, okay, their relatives, the risk in their relatives is less. You can see this pedigree here. This boy with autism, let us say hypothetically he has 10 sisters and 10 brothers. So here, out of the 10 sisters, you can see here the autism it is highly penetrant. Only one person is affected. But here, if you see the siblings, more number of people are affected. So when you see the relatives of a more common gender, yes, there is a variability, but it is more intense in the females than in the males. It is if you take all the causes of all the causes as liability curve for ASD, so in general population also you will see all these factors, but we will be calling them as affected only when it crosses one limit. So that's something like Shishupaladu. So after 100 mistakes only, then Krishna will come into picture, right? So to kill him. So similarly here there is a threshold level of liability wherein we can call them as affected. You can see here the darkly shaded one and the lightly shaded one. The females are less affected and males are more affected. The threshold is different, but the liability level is more for females than the males. So I will not go into the details, but to simply I want to tell that the relative risk of ASD among offsprings of the undiagnosed siblings, they are not having autism. Okay, if you see the offsprings of this affected individual, it is expected that we find more incidence in the woman than in the brothers if it is passed on from this offspring. Coming to the candidate gene studies, earlier we were focusing on specific gene. What is a candidate gene? You are suspecting some gene to be implicated because we got an evidence at some chromosomal loci. That is called positional candidate gene. Or it can be a functional candidate gene because I know their nervous system, there is some problem in the neuronal networks, something to do with the neuronal pathway. Okay, let me pick up the proteins which are implicated in the neuronal pathway. So like this, we can pick up positional and the candidate genes. Earlier studies were mainly focusing on this, like Hox family genes and the Wnt genes, but they were all inconclusive because they failed to show association when they were repeated in other populations or other studies. So they were mostly inconclusive. Later, they studied genome-wide candidate analysis where some of these genes were listed to be having a major role in ASD, like RELN, NLGN3, neuroligin 3 and 4. And as Dr. Arun said, UBE3A, which is also implicated in many syndromic forms, is identified by candidate gene. So this is a beautiful picture. You can see here the same neuronal pathway, but you can see different candidate genes. P10, which is associated with Cowden syndrome and ASD, MACP2 with parent of origin effects, SHANK3, which is important for scaffold proteins with neurons. So different functions of the same neuron, same cell type, but you can see so many different functional genes associated. So this is one more example called as RORA, rare related orphan receptor. Only one gene, okay, but see how the impact is. Just a small one gene mutation or one gene defects could be linked to so many genes because it can influence the expression of several genes of several pathways. One small gene, if you're this is called as a major gene because the mutations in these are going to affect different aspects of neuronal development because it regulates many genes. Coming to the genome-wide association also, yes, primarily they took monogenic causes and they tried to screen which genes are associated. They took Rett syndrome, Fragile X syndrome, and so many other syndrome forms. They could find some set of genes associated mostly with the synapse function, transcription regulation, and chromatin remodeling pathways. This is one more beautiful mechanism in autism spectral disorder. I hope some of you have already heard about it. Post-zygotic DNA mutations, somatic mosaicism. That means once a zygote is formed, when it passes through the developmental stages, the cell will be dividing, right? That means mitosis happens. So in the body cells, that is somatic cells, there is some change that is happening because of which the same individual, the same fetus will have different types of cell lines. They are genomically different. If you take the blood cells or any tissue cells, they will have two different genomic versions. So that is called as mosaicism, somatic mosaicism. Around 3 to 5% cases of ASD were shown to have somatic mosaicism. So there were three major studies, whole exomes analysis of 5,947 families were studied, and they found somatic pathogenic variants, mostly associated with the enhanced expression of the tissue that is amygdala, which is important for emotional response, social awareness, and all. Similarly, there is one more study by Dow et al. He found the risk genes mostly associated with the coordination difficulty and gait disorder because of the expression profiles, differential profiles in cerebellum. Then Fried and Pestner, he also studied 2,288 families, very large, it's a large sample-based studies. They also found mosaic variations, but one of the prominent out of 25 which they found was SCN2A, sodium voltage gated channel alpha subunit 2 protein. As I will not cover because Dr. Aaron has already spoke about the copy number variations. Simply, I can tell copy number variations are submicroscopic structural variants. They count to 10%. And out of all the CNVs, most of the CNVs were falling into two loci, 15q and 16p loci. And one more interesting aspect is that when you take this loci, 16p loci, the culprit loci, the suspect loci, there are so many genes. The loci has so many genes, around 25. And all these genes are known to have some kind of modifier effects. What does that mean? See, not that if you study mutations in one gene, they may not be actually causing it. But there are so many genes, so they have influence on the neighboring genes like position effect variegation. So the interactive effects, the cis interactive effects between the genes at that loci can also result in the complex phenotype. So this is one clue for us why ASD is so complex. When mutations are involved, yes, they can have a straight phenotype, a distinct phenotype, but no, because of the role of modifier effects, we now know that it is causing this complex phenotypic spectrum. Now, if you see the genes such as SHANK3, DPP10, and all these, the scientists came to know that there is not only the structural or cis effects, there are dose dependent functional and structural effects. Okay, that means the mutations could be there, but how they express, how much they express will be important aspect. Coming to the epigenomic variants, that as I told you, the histone modifications are the modifications on the DNA nucleotides. So they also play a role. They can also cause diverse disease phenotypes. Around 50 monozygotic twin pates were studied in one of the studies by Wong et al. And they saw so many footprints. so many clues about where or which regions are highly or differentially methylated. And large scale epigenomic studies have really paced up to quickly identify what are the ASD susceptible genes. We were a bit slow with ASD because of the complex technology, but available technologies like large scale epigenomic and genomic studies helped us to decipher a big list of proteins of different pathways. So these are some of the things you can see. The right side schematic, prenatal epigenetic reprogramming. Because of the involvement of maternal uterine environment, there are so many specimens which we can take at the placental level, because maternal serum markers, that is when during gestational period, even because of stress or some influences, or because of folate metabolism, poor nutrition, diet, or the environment itself, or anatomical changes, maternal metabolism is different, or toxic exposure. So many aspects could be there that control the epigenetic mechanisms during that developmental phase. So the prenatal epigenetic programming is one important aspect to consider to start with, to understand the differential functioning of the genes. Like one of the aspects which we can pick up is nutritive factors. There are so many minerals and nutritive factors and hormone factors which could be implicated in autism, and which are all showing abnormal levels during the gestation and also during the developmental stages. Lastly, we have what is called as transcriptome analysis. What is transcriptome analysis? We are studying, see, at the genome level, there are mutations, but their impact on the pathophysiology is only happening when they express. So the what is the expression status of all the genes that are elevated or downregulated in autism at a particular point of time. So if you study the RNA, or we do the RNA profiling by transcriptome studies, also we can see which are significantly differently regulated. So these are some of the genes where we also saw that some of them are replicated. So we can confirm, yes, KCN gene is definitely there, Shank is there. So all these genes are again proving, emphasizing that these genes have to be picked up. In all studies, these are the common genes. So let us study them first and see if we can use them as diagnostic or for treatment purpose. Now, to understand the different genetic aspects, because we cannot study directly the cells of or patients by in vivo models. So directly on the clinical level. So we have what is called preclinical level testing by using different models, both cell and animal models. So particularly the cells of the brain have been taken up to understand the neurodevelopmental timelines or the pathways. And different non-human primates have also been studied, particularly in the Western countries. But in India, we are mostly studying the mice models, and recently chick models also have come into picture. So people ask me, so we have seen something on the internet. There are so many in Noida in Mumbai, they're offering stem cell therapy for ASD. Is that true? Since we don't have any cure, we are left with no options. So does stem cell therapy hold some promise for the cure of ASD? I say, please don't consider that, because still it is in research and people are testing different models at stem cell in stem cell level. But therapeutically, it is very, very different because of the variant responses from the patients, and also age is an important criteria. However, we have to go on with the research. We have to dig out in detail to see, yes, can stem cell therapy be used in future, or we can do stem cell programming to suit or to use it at early in the prenatal or the fetal stage. Or of course there are so many ethical considerations, at least to understand, to comprehend the biological aspects of ASD. This will be useful, but this is a far more distant hope that I can tell about confidently. So some of the global level genome projects which are already ongoing are AGC, AGRE, Collaborative Programs of Excellence in Autism, and so on. So you can see mostly I follow NICHD and NIMH, but now in India also we have so many autism team works that are coming up, definitely doing wonderful. job by studying various aspects, right from metabolism to the genetic aspects. So, what are the future perspectives? Having said so much about different genetic mechanisms, what is that? What should be our approach in understanding or to studying the genetic mechanisms? So, one is subphenotyping. Most of the studies so far were collectively considering all the autism as one group and studying, because of which we are not able to have molecular profiles for each subphenotype. So we should categorize ASD into subphenotype. Like one of the recent study, I don't remember his name. It is in 2023 in January only. I totally forgot his name. But what they did was, it was a unique strategy. They have taken only non-verbal or ASD cases, and in those cases only they focused on the set of genes. They pulled down the genes that were going wrong, and they could find out some important clues, and it is one of the enzymes that they came to know about. So they want to even target that particular gene and see if there is a regression of ASD. Similarly, mapping the genetic and the brain diversity. What happens in the brain during the development? What kind of genetic aspects are controlling the brain development in human? And refined animal models and clinical trials. So we go by the intuition that, oh, somebody studied this one, let me start with this hypothesis. But it's not like that. We need to comprehend the information, test ourselves, and from the crude level, be tested properly at the clinical level. So what I want to say is, definitely collective effect of both the clinical and the scientific community. We have to have a committed efforts on understanding this autism in detail, so that we actually comprehend the information both at the all the molecular level, that is genome, transcriptome, and epigenome, and quickly find markers which can help us at least with the prenatal screening. Because since there is no cure, no hope to, and people are suffering, even seeking help or giving care to the children, definitely we can do something at the prenatal level and just warn them about the signs of symptoms that they are, about the onset of ASD that could happen, particularly placental or perinatal and environment defects. So thank you very much for your patient listening. I hope I could reach you all because it's a diverse group and a short time. I hope I did my job well, but I will be happy if you have any questions about any of the aspects that I have covered just now. Thank you all.
Thank you so much, Dr. Sandhya Ma. We are so glad that you could show and explain these concepts to us.
And it is a very excellent and effective lecture, and you have made the complicated subject into a simple one. Every couple and every family, they want a healthy and active, intelligent child, very socially active child to carry their legacy forward. But unfortunately, nowadays, the autism problem is becoming more and more. Even as per WHO, it is 1 to 2% it has become. So everybody should be very careful, and the mothers should be made aware of the first 3 years of the child, how the child is behaving, and the milestones also they have to take care. So it is our responsibility, whoever knows the subject, it is our responsibility to create awareness among the people to prevent this. One more thing just I wanted to add is this problem is in the amygdala and cerebellum and in the brain. So Dr. Sanjay was telling, it is post-zygotic DNA mutation may be there. So in that, the reasons are, one is diet. So during that period, antenatal mother should be advised about the diet and environment, and we should focus our research on that aspect. What is causing this mutation to result in this disorder? So I thank Sanjay and all the speakers, and I'm very
Ma'am, can I
grateful
invite
for
Professor
sharing
Rao
their
for the talk?
and Dr. Gargi will introduce VR Rao sir, Professor VR Rao sir. and he will give his advice on this. Thank you, Sanjay.
Okay, thank you very much.
So thank you everyone for all the presentations so far, Dr. Nandini, Dr. R, and Dr. Sandhya. I'm going to invite Professor Rao right now to talk to us about one success story that he's seen. He's the Dean of Research at Genome Foundation, and he has more than 35, 40 years of experience in human genetics, anthropology, and I don't want to go into his credentials. There's so many. I don't know how to stop or when, but we will entertain all questions at the end of Sir's talk. I'm sorry to say that to stop any queries right now. Well, Sir finishes, then we'll take up all the queries that are there. Sorry for the delay.
Thank you. Thank you, Gorky. How to video screen,
Yeah.
How to share
Yes, sir.
from where? From
Yes,
this?
sir. So on the top of your screen, there should be a red button, leave on the side, and then next to it there should be a share button. Share.
On the screen?
Yeah, on the screen, on the top, you have a
the red button, yes.
yes. Next to that, there's a share. Yeah.
Okay.
You press share. Once you press share, it will.
I am pressing the that button, red button.
No, not red button, sir. Share button. Share button. Next to the red button.
Share nahi aaya. This is tab is using what is this?
Yeah. So now it says screen, window, or tab to share.
See, this is meeting Microsoft Teams करके है ना ऊपर.
Yes, sir. Yes, sir. Yes, sir.
उसी में है.
Right below that, you will have share button, sir.
Teams.
There is chat, people, raise, react,
Chat.
After that, you see, sir, there should be a share button.
Chat का बाद share.
Chat, people, raise, react, view.
I don't know. I'm going back. See my screen,
Yes, sir.
you have that, video on or mute. Okay.
Yes, sir.
Voice mute. Then you have arrow.
There's an upward arrow. Upward arrow.
Yes, sir. Arrow click change, sir.
Arrow, yeah. Then you see.
Arrow, yes.
Yeah, that is true.
Yeah.
Now share. Okay.
Yes, sir.
I have to go to screen share, no?
Yes, sir.
Okay. The screen is shown. Is
Not
it sharing?
yet, sir. Not
yet,
sir. Not yet.
Oh. Then you have here entire screen, window, Chrome tab.
Yes, sir. Yes, sir. So you click on window, click on screen share. Entire screen you
entire
see.
Screen share, and then window.
And then there's a share button at the bottom. Says
yes.
Share. Again, there's one more share button. Now it should come.
No, there is share button is not highlighted. Entire screen I have put it.
Click on the window, sir. Click on that. Click on the entire sheet.
Yeah,
click on the entire screen. No. Click on the entire screen. The screen
okay,
is shown, no?
Yeah.
Now it will highlight share.
Has it come?
Yes, sir. Yes, sir. Your screen has come.
Okay, full screen has come.
Your screen has come, sir. Yes, sir. Now it's
yeah. Thank you, Gargi.
No problem.
And Dr. Gandhi Garu, if you are already there, and thank you very much for organizing this, encouraging us. Now, Chairperson Dr. Karankapusham Garu and other previous speakers, Dr. Nandini, Dr. Oren, Dr. Sandhya, and all my colleagues, and patients and parents. Patients, parents are also there, among the audience.
Yes, sir.
You have audience also, patients, parents. Okay, all the parents, and thank you very much. You see, while I was listening to our genetics part, In fact, what we do now in Genome Foundation, they come either by reference. Clinician refers patients. Okay. Sometimes patients directly come. Now the issue here is the clinician is expecting some therapeutic intervention. Diagnosis is one part, and is there any treatment? That is what clinicians query. Even Dr. Nandini must have, after hearing these elaborate lectures on genetics, I'm sure she is confused. Okay, as a clinician, all this, genetics, so many genes and all is confusing. But they want something, something to be delivered, something. That is what is coming up is precision medicine or precision advice. These are the issues, Now, when you look into the genetics, as was deliberated by our previous speakers, yes, lot of genes are there, lot of pathways is there. We know biology is complex, okay, and transient. But mind you, what is happening, all these biological pathways, research is going on, but at the same time, the technology has also developed. In terms of, let us have some, in terms of paradigm shift, what we call it, whenever, genetics is being practiced or in clinical practice, genetics importance, we need to be, there is a drastic change, Earlier mindsets are different from now. Paradigm shift. That is, one is clinical practice. Clinical practice until now is symptomatic, even now symptomatic, but causative. The shift is going to be causative. Okay, people want to know what is the cause. Okay, I do understand. A lot of genes are there, but lot of genes won't be in this one patient which I'm treating, which I'm consulting, which I'm concerned. Here is the patient is one. Genes may be there, pathways may be there, but this boy, this girl, this patient must be having only one pathway, only one gene, which is responsible. That is what the issue here, causative gene. Okay? If the causative gene is known, then there is intervention possible. There is therapeutic intervention. There is, in terms of, even counseling, prenatal diagnosis, counseling, all that. So this is one clarity what we need to have is that, yes, biology is complex, a lot of genes are there, but a patient will have only one pathway which is causing the disease. And again, one patient may be having one gene, another patient may be having another gene. There is a lot of diversity. Okay, that is important to understand for complex diseases. Now, this basic research, whatever we do, the understanding as of now is Mendelian phenotype, Mendelian disorders, like even autism spectrum disorders, we have Rett syndrome. The inheritance pattern is Mendelian. So we know the mutation with the penetrant, this mutation is causing Rett syndrome. That is possible because it is Mendelian disorder. But a lot of autism spectrum disorders, excluding syndromic. Let us not go into syndromic, unless until you want to understand autism as a phenotype, autism, genes for autism, and cause for the autism. Let us first look into non-syndromic. Syndromic, there is other approaches, but I'm only concentrating on non-syndromic autism. Okay. Yes, there are spectral disorders. There are spectral in terms of several clinical expressions, that we do understand. But now if I go on subtyping these subtypes, of a non-syndromic, I will be lost. Now the approach is entirely different. You come from the genes to phenotype. Okay. If I take this individual non-syndromic, I go for approaches, like whole genome sequencing. A lot of approaches are there. Then I will come to know what type of this phenotype. Among the spectrum of disorders, where is my patient? Okay. Then comes intervention. Okay. That is one understanding. Another understanding is like this. In non-syndromic, the whatever candidate genes, we are talking about, and also pathways, several pathways that have been built up, except some few families, they found a gene and mutation, okay, which is again, coming to Mendelian type of inheritance. Understand, in complex phenotype, there are rare variants, rare genes, okay, rare variants of genes responsible causing the disease, that is with major effect. So with this type of some type of clarification, understanding, the approach to genetics completely changes. When you have this type of orientation, now I am able to, in fact, help clinicians, and also I'm able to help the patients. Okay, only my mindset has to change. The patient is an individual entity. He is a complex biology. I understand. A lot of genes are there. I understand. But in this patient, there must be something what we call a gene with a major effect and mutation. All the complex diseases, even type 2 diabetics, even cardiomyopathies, we found major mutations. How major mutation causing the gene, causing the disease. So here also there are, though there are several genes, ultimately it is a question of what methodology approaches you are using, so that you are able to identify the driver mutation. Okay, that is what the challenge now. When you look into the approaches, multidisciplinary, of course, it has to be multidisciplinary, and the technological upgradation, technologies that are at your disposal, okay? All these technologies are there at your disposal. Suppose you want to do genetics, genomics. There is whole genome sequencing, and now the PacBio long reads have come, because whole genome sequencing, we are missing some long deletions in some inversions. So long reads has come. Now there is single cell. You take single cell and you can do whole genome sequencing. And the question is whether the cells, whatever basal cell or cancer cell, whatever, wherever the neural cells, whether the genome of the cell is different from the genome of the individual. These are the issues that are being answered. So technology point of view, these things are developing there. Whole microarray. Yes, I can understand all chromosomes microarray. In terms of cell and whole exome sequencing is one thing. What I have red lighted, though these things I am planning or already planned for the patient who came to us, and about that case I will describe later. This is what we are going to use. Whole exome we have used, metabolome we have used, untargeted, targeted. There are several things. I went for untargeted, and also gut microbiome. Also there are targeted, untargeted, but I am going for untargeted for my own reasons. So what is important here is what approach you will take up, based on some sort of background understanding of the disease at hand, and also in terms of cost. What cost? Okay, these you have to evaluate, in terms of cost and benefit. How much benefit I get? If I get only by whole exome, before that, Sanger sequencing, if I get a mutation, that is fine and good. But Sanger sequencing for such type of diseases, where I have to map a mutation, so I need to go for whole genome sequences. Among them, I chose whole exome to be in terms of cost effectiveness. And all these technologies, it is not that Genome Foundation have all these technologies. No. There are service providers, there are technologies, service providers, they give you service, that's all. You have to identify the best service provider and do your science integrated approach. And your approach, what approach you take up, that is up to you. Okay. Now for our, this particular whatever plan we have is that understanding these integrated approaches, it is also diagnostics and also understanding biological pathways leading to therapeutics. Okay, what you call theranostics. Now the theranostics is the catchword, combination of diagnosis and therapeutics. Therapeutic interventions, gene therapy, biological drugs, novel repurposing. We are, in our case, we are looking at repurposing. There is a possibility. And then functional validation, stem cells, induced pluripotent stem cell derived brain cells. We can create from the patient which I have a brain cells, from pluripotent cells. Now the question here is, there are expertise in the country. Okay. Only you have to talk to them. I just called this group, who are in Delhi. They are doing functional organoids, brain cells. They are creating in the lab, and they are into mental disorders, global developmental disorders. And there is a group from AIMS neurologist and Dr. Soumi Pati from Nadar University, Shiva Nadar University, Noida, and JNU. There is Saroj, Dr. Saroj. So all these people, they have formed a team and they are going from theranostic type of approach. Okay. Now gut microbiome. This is a very interesting, type of intervention. I think in all the diseases. Yesterday we had a webinar on this particular gut microbiome, and we were talking about, several diseases, even autism. We were dealing with DMD, and also there are SLE cases, obesity cases. Okay, all are lined up for us at Genome Foundation. We are going to take it up. Okay, and this is a prebiotics. It is an intervention here is gut microbiome is by intervention by nutraceuticals. You have to nutrition. Through nutrition, you can introduce some metabolites or prebiotics, probiotics, symbiotics. All this, combination of several bacteria based on your own bacteria, what deficiency you have. Lot of avenues are there in terms of intervention. Already it is in clinical practice. I will show you a few slides, because it is a tremendous possibility for application in ASD. Living inside every person are trillions of microorganisms. From birth to death, they are there. Okay, there are several bacteria, viruses, fungi, and other life forms that are collectively known as microbiome. We call it microbiome. Okay. Now, various organs have distinct microhabitants. Skin has got their own distinct microbiota, and like that, gut microbiome. The group that has attracted the most attention in clinical practice, in biomedical research, the microbiota of the gut has attracted more attention. We all know gut-brain axis. What you call gut feeling, the people say it is gut feeling. Okay, we know that axis is there, and enter from our stomach, intestine, direct to brain. There is a nervous system, enteric nervous system. It is a bidirectional connection. And also we know vagus nerve. Okay, we know several metabolites in the gut. They, like, microbial organisms also have some metabolite like short chain fatty acids, and they produce some metabolites. Neurotransmitters. We have done a lot of work on 5-HTT for our depression project. Okay, immune cells, epithelial cells. There are a lot of these organisms produce metabolites. In fact, this 100 trillion bacteria which we have, they also have genes. Okay, all these bacteria have genes. Those genes, those products interact with our human genome. Imagine, mind-boggling. And now we have technology for that. Shotgun approach. If I do shotgun for this my fecal sample, DNA, after extract DNA, I'm going to get all the genes of all organisms. And I see my own whole exome, I have the data. And metabolome I'm creating. So interaction, integration. That will give you clarity about the pathways and also even therapeutic interaction. This, is very in terms of this microbiota, gut microbiota. Already, people are in clinical practice. They're using it. Okay. Yesterday we have a speaker, Dr. Sumit. He already treating the patients, and I told him he should come to Hyderabad. Okay. Once I have about 10 patients, I will call him. He is what is called now, is a microbiota functional nutritionist. He is a MD microbiology. And what he's helping people, is like that microbiota and design probiotics, prebiotics, whatever, symbiotics, and also nutrition. And that's what we call these expertise, microbiota functional nutritionists. Okay. In fact, when I was reading the papers, I was really, I read one paper about functional nutrition they mentioned. Immediately, I sent a mail to the Singapore, Dr. Mrs. Jayaraman. Singapore, she's heading a unit of functional genomics there, functional nutrition genomics. I asked her, Madam, who is in India, very functional nutritional genomics? He said, Doctor, it is still in the developing stage. But fortunately, I met Dr. Sumit in Benares in a conference. And he told he is an MD microbiology. He is taking a lot of interest in it. And he also knows what is happening in the field. Then I told him, you have to join our team. He has agreed. Now here, the dysbiosis, all the microorganisms, they're supposed to be in some proportions, good bacteria, commensals, and not good bacteria, authorities. But always, what type of bacteria, this bacterial species, at genus level, or species level, family level, there need to be some sort of homeostasis, okay? And when the diversity decreases, the problem comes. That is what they call it dysbiosis. Any disturbance in microbiota can be, they may not be causing autism, but they will be participating in the severity of the autism, in the expression of the autism symptoms. Okay, so we can reduce the symptoms, we can modulate the symptoms by modulating our gut microbiota. That is what the issue. Now here they have shown that bacteria, protobacteria, bacteroides, this particular genus, and firmicutes, there are two species, genus level bacteria. One is, increasing towards impaired social interaction, communication, restricted patterns of interest. This is, they are towards autism, okay? Whereas it can reduce. If you firmicutes can reduce, but both of them are related to toxic metabolic production. Okay? So here, inflammation. One is inflammation, another is neurogenesis. This our bacteria plays an important role. Now I have the present case. My case is I'm not revealing the name, and his present age is 16 years. His mother is there among the audience. Okay? And ASD diagnosis is at 22 months. Management, excellent home care. Mother is terribly, she's fully involved. She left all her whatever his studies. She's a well studied person, but she left all that and she's dedicated to this boy. And behavioral therapist, report is very encouraging about this boy. I'm not going into clinical detail. A lot of clinical details have been, Dr. Nandini has, in fact, she has dealt on that. And what this family is doing, one is the excellent home atmosphere, and they have a good behavioral therapist and neurological occasional consultation they have. They approached Genome Foundation for genetic testing. We planned, after looking at all that, whole exome sequencing, metabolome, gut microbiome, integration study. I'm sharing genetic results now as a success story. Okay, metabolome and all these analysis are going on. But gut microbiome, I'm about to collect people samples. But I'm sharing here my genetics. I call it a success story. Hypothesis-free model. That's what we always need to do whenever these complex phenotypes are there. There may be genes, several genes, but we cannot go on swapping those genes in our patient. Patient is only having one gene. So it is always better to go for hypothesis-free model. We sequence all coding regions of all human genes. G6PD gene. In fact, we have been working on this gene. I have worked several populations I have screened. But the issue here is even a bioinformatics person who is working, giving you the reports, he will miss this gene because it is not related to autism spectrum disorders. Autism, G6PD gene, never is the candidate genes it is there. Then this company fellow who will give you a report, you only say, oh, no, G6PD is not related. He will remove it. But we do differently. Ours, what we do is a little bit, because we're all trained in terms of human genetics, even bioinformatics person should be human genetic. So rightly you point with this report is that it is a G6P deficiency. This deficiency is a Kerala variant. See, it is not the question of Kerala. They found this mutation in one Kerala boy. Okay, at that time the name came up, but the mutation is well known. It causes G6P deficiency, and the G6P deficiency levels also we can see. It's a moderate type of. There are severe deficient mutations with very less production of G6PD activity. But this particular deficiency mutation, we have a moderate level of. In fact, I have asked them to get G6PD reactivity report. Okay. Now, how the G6PD is involved in our autism disorder? You see, role of G6PD deficiency and its association to autism spectrum disorders. My God, when I went to literature, always, Genome Foundation, we have a strong research backup, and we never give a report for report's sake. We will give the report looking at all the aspects of research, and what is the current status, and if the report before doing all the tests, while doing tests, we will organize ourselves with research update and accordingly choose approaches. When the report comes, we are ready with a lot of information and guiding the clinician and patients. Now here, G6PD takes an important role on oxygen transport. Okay, in fact, NADPH, which is one of the products, this enzyme in the body, it is really interesting to know this particular molecule takes care of all oxygen transport in the body. There are several other pathways we don't know, but there are of minor role. Major role is by this NADPH. And detoxification. When oxygen transport, what happens? Free oxygen radicals will be there. That will be toxic. This enzyme, in fact, detoxifies our reaction oxygen species. Otherwise, it is going to be pathological. So this enzyme, actually G6PD and red cell enzyme. Red cell, it is a hemoglobin. it carries oxygen, But NADPH is one molecule which transports, okay? But also it takes the role of detox, removing uh, reactive oxygen species, extra ions, this oxygen, it removes. And detoxification is one part, and prevention from oxidative damages. Because because the reactive oxygen species, there will be oxygen damages, organ damages, so it prevents it. Proper neuro also they takes a play role in proper neurodevelopment and establishing synaptic plasticity. Okay, neurodevelopment it is involved and establish synaptic plasticity. Through one way is oxygen transport, another is folate metabolism. It plays an important role in folate metabolism and nucleotide synthesis and DNA synthesis and neurodevelopment. You see, both pathways, it is an important enzyme for our neural development. Now, because of this mutation, what has happened, this NADPH is not produced or produced less, and detox ROS has increased, accumulation of ROS, and oxidative damages, neuroinflammation, microglia activation, neuronal dysfunction, ASD. And both routes, folate metabolism dysfunction, impaired nucleotide synthesis, and neural dysfunction. And 6-phosphogluconate also directly involved in nucleotide synthesis and DNA synthesis. And here also, because of that product is not there, it is also impaired, So ultimately, this is a neurodevelopmental disorder, which is due to inflammation and also oxygen transport mechanism, okay? Now, G6PD is found in the cytoplasm of all cells. Actually, this is a housekeeping enzyme. It plays several important roles. A vital role in the prevention of cellular damage and reactive oxygen species. So this enzyme plays an important role in the prevention of cellular damage, especially this particular our neurodevelopmental, that there is damage, and that is what has happened, and also inflammation. So what that particular when I spoke to Dr. Professor Pati, what they are planning, in terms of they have shown these pathways a lot in the publication. They have shown all this and how microglia, activated microglia, and reactive oxygen species is increasing. Pro-inflammatory cytokines are increasing, and neuronal death, hypomelination, synaptic dysfunction, both your astrocytes and microglia. There is a problem. So what she was planning to do, in fact, when I sent a mail to her, she immediately called me and she told that, Doctor, we are already doing some this type of, they have 2 cases from Saudi Arabia and 1 case from AIMS, Delhi, and G6PD deficiency, and autism. Okay. When I told autism and G6PD deficiency, immediately she called me, and she is planning. In fact, already she has a support, for intellectual disability disorders. He has been fully funded by the DBT, SCRB, and so she has already doing experiments. Okay, and she said that your patient can always join us, and this, as a support, research support is there for them. Now, what she says is there are, she can create, in fact, organoids. Okay, iPS is derived brain cells for the patient specific. She needs only blood sample from that monocytes, from that iPS cells, and then derived brain cells. Okay, why that is required? Now, therapeutic strategy is what is written, is like this. Increase the NADPH production. We have to increase NADPH production. Okay, our G6PD deficiency pathway, there is some problem, But is there any other pathways, where NADPH production can be increased? That they are telling metabolites, cellular metabolite, malate and isocitrate. They are going to do this. When they have these therapeutic approaches, they are going to use this to validate in stem cells. That is what their objective. So they have a plan of malate and isocitrate, and these are all effective therapeutic, cost effective. Okay, that is what one idea. The other idea is which these people targeting GCPD agonists, melatonin. In fact, when she was speaking to me, I told melatonin. Melatonin, then I read a lot of articles are there. Melatonin increases GCPD activity. That much so. Okay. Now, whether it could be a therapeutic intervention. Now, melatonin, I also spoke to the mother of the patient. She said that the neurologist, they have given this boy melatonin for 1 month with a dosage, and that because he was very aggressive and he was sleepless next day, then this has improved his overall whatever behavioral activity. 1 month they have give, after they stopped. Now melatonin across neurologists, they have limited type of dosage, and they, as a drug for this autism, it is not yet. There is a biological alternative, but melatonin strips are available in the market. If I am not having good sleep, I can go to the drug stores and get melatonin strips and patches, melatonin patches. I can put melatonin patches and sleep. So this, what is happening in this project, what you want to do is that melatonin, whether in that organoid brain cells of this particular patient, she want to test, different dosages of melatonin for long-term duration. Okay, and that is one thing. But my request to her is that, Madam, you have to organize among the neurologists. Our patient has got a neurologist and AIMS neurologist, and you people are also there as a team. But we need to have some sort of organized meetings so that this melatonin therapy, whatever neurologists say, low dosage, long term, or intermittent dosage, some sort of intervention is required. This is what, and also neurologists will be the best people, to advise how to administer this drug. That meeting we are going to organize. Then other important thing, what I'm telling you, this fellow gut microbiota role, it is significant pathways. They are epigenetic role. They play a very important role in epigenetics. Okay, and there may be some significant pathways. And if I do microbiota, then there may be some. I am going for untargeted microbiota, and also the whole genome sequencing I have. Metabolome also I already done. Analysis is going on. If I put untargeted whole microbiota, all the genes of microbiome which is there, then interactions. I can have an interaction of all these metabolome and microbiome and genome. How they are interacting. What is the pathways and all, it may be a research program, but we are not, we are also thinking in terms of immediate intervention. One here is melatonin, another is gut microbiota. Stem cells, that's what I'm talking to you. She is going to create iPSC derived patient neural cells, okay, neurons and glial cells and also she will test all this therapeutic whatever. First thing is deciphering the intracellular pathophysiological mechanisms. Mechanisms can be understood by this, and also she will be metabolites, therapeutic metabolites she will test in this stem cell model. Thank you all. This is all I want to share with you. And there is, what my final understanding of genetics, lot of scope, only how you approach the problem. Okay, research is one thing, but after doing research of 30 years, I realized I need to deliver. And when I started it, not only in this case, other case also I'm getting involved. Okay, thank you.
Thank you
Any
very much,
other-
sir. Thank you, sir. Your talk is wonderful and very useful and stimulating. Very nice. You say genetics is the reason or cause for anything, and solution is also in genetics. Everything is in
No,
genetics.
madam, one statement I missed to do. You see, without genetics, there's nothing. Okay, whatever
Yes.
you are, okay, your behavior, your skin color,
Yes.
everything is
The
genetic.
entire
Yes,
Srishti is
environment,
genetics.
environment plays a role.
Yeah.
Environment plays a role. That's why
Yes,
no,
that
in
is
that
true.
microbiota, we are going to take care of lifestyle management, nutrition,
Elias Lubaldaram.
immediate intervention.
So, thank you very much, sir. Thank you. So, the essence of this webinar is mainly to create awareness and also to find out the cause and to how to prevent. Like I told earlier, during the formation of central nervous system in the embryo, the mother should be very careful, and the doctors or other people who advise her should be aware about the drugs, diet, and environment. Even software, this exposure to this software people to the screen also may be a reason, we don't know. At that time they may miss a period, they may not they recognize that they have missed a period, and at that time the central nervous system is being formed. That also may be a reason, we don't know. We have to search and find out. And the management, as our professor told, prebiotics, probiotics, symbiotics, and stem cell treatment also nowadays many people are giving promising results. And microbiota, which is actually it is more cost effective. All these things should be thought of, and all of us should work together. All groups should come together, work together, and find out a solution and take more on this day of autism day, world autism awareness day. Thank you very much. And all the parents and other participants, they can share their doubts and also their queries on starting, and they will be answered because already it is 2 o'clock. So
No,
already,
madam.
please tell me.
Give patience for parents 10 minutes,
Okay.
okay? Yeah,
Okay,
this
okay.
is interactive. Don't leave
Yes,
it.
yes, interactive webinar, that is true. So
Please,
any
please. Yeah, parents. You ask the parents if they have
any parents and participants, they can raise any queries and doubts. The
they can
speakers
talk.
will are ready. They can talk also. The speakers are ready to interact.
Thank you, madam.
Somebody,
Ma'am, there are two
Um, um,
questions as well, Miss. Yeah, yeah, please go
Introduce,
ahead, please go
Sorry
ahead.
to
introduce yourself
yeah.
and please. Yes.
Yeah, madam, is it related to RTMS therapy? As a part of ASD treatment, I have undergone one doctor in Hyderabad where they have suggested for RTMS therapy, which has given some good results. So, is it they have said like they will give some kind of vibrations to the neuro? That's what they have communicated. I'm not sure on that, but is it a good practice?
Rao sir.
Yes, you see, whatever evidence based. Science requires evidence. Okay. This type of treatments, we know that mental disorders, very extreme cases, they give these shock therapy. Now, when he is putting electrodes, where he is putting, what is he expecting in the brain? Suppose fMRI is taken, okay, already brain image you should take brain image and explain to you what he is going to do with his electrical shocks, treatment, which part, okay. It is very, from my point of view, it is very risky. No evidence based. We need evidence. What is the his which neurons he is targeting, which region he is targeting, who is he? Is permitted? I don't know whether it is in the clinical practice for autism. Is it prescribed?
Okay.
Please look into all those things. Okay.
Sure, sir. Thank you so much.
Natural interventions, are more important. Okay, when you are understanding biology and gut microbiota, whether Dr. Sumit is here, Dr. Sumit I saw earlier, but he must have left, and he got good results. It is not just knowing your microbe, where is the deficiency of a microbiota, okay, and then do some supplements through nutrition or supplements probiotics or prebiotics or symbiotics. What we need to understand, lot of studies on autism where they have found dysbiosis. Okay, but dysbiosis is one patient is different from another patient. We have to do the microbiota. Okay, and Genome Foundation has in place, not only autism. We have complex diseases. This is our approach. Okay, and we have experts. I am a geneticist. I do genetics, but I have metabolic expert from Manipal Institute of Life Sciences. Okay,
Yeah,
and I have this microbiota, Dr. Rawat from Sagar Medical College. He is MD microbiology. So multidisciplinary, multi type of approach, integrative.
Sure, sir.
We have to see the patient and understand, then accordingly we can improve.
Next one, please. Next.
Good afternoon, sir. I have a doubt regarding, as you were mentioning about gut microbiota, how much the home diet make changes in that? The one medication that you said you guys can provide is different form, right? But how much?
Madam, voice is not clear. What is you are asking microbiota?
My
Yes,
question. My question
Yeah.
is,
Yeah.
will our home food that we give at home, that makes
Yes.
will that make any changes in the gut microbiota?
See, first thing, madam, what we are planning is to get fecal samples and do microbiota. Okay. Now whatever supplements which are talking home treatment. Okay, is your own treatment. Even now we take this probiotics, prebiotics, but there are several varieties of probiotics. That depends upon what is the diversity, microbial diversity in the patient. Okay, and then try how to enrich that what is lacking there. Okay, madam. That is by our microbiology functional nutritionist, who himself is MD microbiology, and this can be given at home. Am I right, madam? Have I answered your question, madam?
Sir, what I am understanding here is of the patient, you do fecal testing, and you will understand which particular microbiome is missing, and then we will accordingly suggest the the treatment. Is that what you're saying?
Yes, probiotics. Probiotics is being prescribed in clinical practice. Okay, well, we take probiotics. Okay, and now they're all safe. They're all safe tested drugs, and these clinicians they prescribe sometimes. But what we are looking at is very specific evidence-based probiotics combinations. See, this science is going such a far that fecal transplant, fecal transplantation, okay, fecal matter in capsules of a normal person is being given for melanoma. Melanoma is a skin cancer. They got very good results. But fecal transplantation in India, as of now, we don't have proper, guidelines. In fact, it is regulated. Okay, because there are issues there in terms of suppose one unknown mutation or gene comes into this fecal, whose fecal normal, you think normal, whether he has been screened properly before giving the as a transplant. These are the issues. But it is going to come up soon. Okay, guidelines are emerging, and this is going to be soon. In fact, gut microbiota is being done by our enterologists, who are dealing with bowel diseases. Okay, we have an institute of bowel diseases, and that they do more than 200 gut microbiota sampling. And I asked, madam, I have autism or other cases, whether you can interpret. They have a total channel, they test gut microbiota, they have a clinician, they have a nutritionist. I asked them, whether you can take up these cases if I refer to you. But they said their mandate is very clear. They only do with enteric diseases, bowel diseases. They have their nutritionist trained in that. And that type of package is there with them. But we need to evolve a package, that's why I was looking into here and there. I got this Dr. Sumit with us, and also metabolite, life sciences, Manipal Medical College Life Sciences. So this type of intervention, or service providers, though they are medical college and doing research, they also give service. Okay, like that, we have to get together as a team. Ultimately, translation is in terms of therapeutic intervention. No, the question is now is whether the boy will improve immediately, how much time of this therapy. There will be improvement. That's what Sumit says. There will be improvement. The dosage and all depends upon how early we're intervening. And neurogenesis is throughout life, madam. It is not that neurogenesis stopped. And the neural cells, they have that plasticity that is known in biology. So we are anticipating that some intervention, a positive intervention, evidence-based intervention is possible. They may improve some outcomes.
Can I say something?
Madam?
Yeah. So what you are saying is, by working on gut microbiota, there will be improvement in neurogenesis.
Yeah. It's not eugenics, madam. It is not eugenics. It is not going to change the genes. We are not saying it will cure the genetic defect.
No.
Okay.
Curing, sir. I'm talking about improvement in the cognitive function.
Yes. There will be improvement, behavior improvement. That we can always have some scales. Before treatment, after treatment, in between treatment. We need to follow up. You see, this type of intervention that helps. This is always madam, individual patient-specific type of intervention. Okay, because one patient, the way he responds may be different from other patients. I have seen after I met your son, I have seen several other was interacting, but. Okay, it is not that they will be having same genes with the differences. We need to identify what are the genes, and how they are causing neuronal nemesis. These things we need to understand. But in this boy, we know what it is.
Sir, shall we close it and then shall we continue the?
Madam, there are other two persons. See, Dr. Kanakbhushan, madam.
Please tell.
Ask them if they don't have any queries. You should close it. Don't close it suddenly.
No. I'm asking.
No. You ask them participants. You see,
Hello.
we have. Yes, please.
Hello, please.
Good afternoon.
Yeah, good afternoon.
Myself, Dr. Pratyusha. First of all, there is a very informative talk. Thank you for it. Yeah. My question is that I have two elder sisters, and both their sons developed autistic features at around 3 years of age.
Oh, okay.
So, yeah, what will be the risk to my baby? She is now 6 months old. And how can I detect if there is any genetic predisposition to it?
See, 1 minute. See, I have to look into the total genealogy, madam. Okay.
Okay.
Genealogy means, I take a lot of information, on the family.
Mm.
And there will be, see, looking at, those two sisters, they are twins or twins, madam, or what?
No,
Those
sir.
two,
There are two different siblings. My elder sister's son is affected with trisomy 21.
Okay.
At around 3 years age, he developed this autism features.
So this trisomic.
Trisomy 21. Yeah. And the second sister's son also developed around 3 years of age. He also had a significant NICU history. He had a RDS and was admitted in an ICU for about a week.
Okay.
So we have 3 sisters, and I'm the youngest.
Okay. But these boys, both they did genetic testing, trichotomy. They have done chromosomal testing for this second boy?
No.
Okay.
Regarding autism, you mean?
Yeah, that whatever symptoms, you say the first case, the daughter, I guess, son.
Sons, sir. Both are sons.
Okay. We need to look into the history and the medical reports, madam. Whatever tests have been done, okay.
Okay.
And we can really sort out the approach. How we are going to address. Okay. No problem. You can come to Genome Foundation. Our contact address will be there. The Gargi will share with you. Yeah.
Okay. I'll contact.
Please contact Dr. Gargi. Actually, they have shortlisted certain genes, though they are number or more. So we can first try.
Dr. Kanakapushna, madam, this approach is something different. It is not shortlisted.
So I'm giving her information.
I am going by hypothesis free. Okay.
Okay.
Hypothesis free. No question of any candidate genes. Each individual is different.
Of course. I'm giving her information. She can come and she can interact with our scientists and Dr. V.R. Rao and contact Dr. Gargi and get the information how to come here, how to take appointment and for testing and all this. Thank you. Thank you.
Okay.
Okay. Any other, please? Any other participants? Hello? Hello? Any other?
I think that's about it, ma'am. I think there was one query in the chat which had come.
Okay. It has come in chat box.
In the chat there.
Okay.
Yeah, so they've already answered. That is already answered.
Okay. Right.
All the queries are answered. Yes, sir.
Okay, then
Dr.
and any other queries also, other queries also, they can be shared in the chat box and it will be answered.
Dr. Nandini is around?
Dr. Nandini?
Sir, Dr. Nandini had a few patients, so she's gone. She said that if any queries are there, to inform her.
I'm very keen to know what is Nandini's, because she sees a lot of patients, The patients need to be helped.
Sure, sir.
Okay? Yeah. Thank you.
Yes, sir, definitely, sir.
Thank you, sir.
Any other queries?
Dr. Sanjay is also there?
Yes, ma'am.
Dr. Arun, Dr. Sanjay, Professor Rao, sir. We thank you very much, all of you, for your patient participation and also for attending this webinar and making it a success. The main aim is to help the parents and the children who are affected by this autism spectrum disorder. We will continue these webinars every month with a new point in helping this disorder. So this is a small beginning. So this is the first step, and let us all come together and make it a success. Thank you very much. Thank you all for your participation. Thank you, ma'am.
Thank you.
Thank you, Gargi, for arranging. Thank you, sir.
Thank you, everyone. Thank you, everyone.
You have given very useful tips, sir, for in treatment. Thank you, sir.
Thank you.
Gargi, Karna can close it.